Thank you very much for joining us. I know that many of you have traveled a long way to be here, and we truly appreciate your time and commitment. My name is Dr. Supapong. I'm head of vascular surgery at Chiang Mai University Hospital. Today is very special occasion of us. It's an opportunity to share our experience about PMEG. And as all know, this field is evolving rapidly with advanced techniques, device, and clinical evidence. We are especially honored to have an outstanding panel of proctors today, representing the leading aortic center in Thailand. I'm confident that their expertise and insight will make today a meeting both valuable and inspiring. At this time, it's now my great honor to invite Dr. Nattapong Khosa Chunhanan, Associate Dean of Faculty of Medicine, Chiang Mai University, to deliver the opening remark.
Distinguished faculty members, honored guest speakers, respected colleagues, international participants, and distinguished guests. On behalf of Faculty of Medicine, Chiang Mai University, and the organization committees, it is my great pleasure to welcome you to the workshop, Sit and Talk, the ideal candidates for PMEG in complex aortic repair. This workshop reflects the strong collaboration between vascular surgeon and experts from Chiang Mai University and our international colleagues with the shared goal of advancing knowledge and providing patient care in complex aortic repair using physician-modified endograft or PMEG. Over the next 2 days, participants will have the opportunity to exchange the experience, discuss challenging cases, and learn both theoretical concepts and practical techniques from the distinguished local and international experts, including live operation demonstration, the hybrid operation room. I sincerely hope this meeting will provide you the most experience and will bring you the technique to help the patients in your care. I hope that you can have this, not only have a good experience in this workshop and also having an experience Chiang Mai. So now it's my opening the workshop today. Thank you.
Next, I would like to invite Professor Kampon Lauha Pensang to give us a welcome speech for all of the speaker and also the foreigner doctor. Please, Dr. Kampon.
Good morning, ladies and gentlemen. This is our first time to have a workshop and an operation like this. So welcome all of you to our institution, the guests from Asian country. We are very proud to have you all here. And for the meeting today will be the lecture and a demonstration the whole day with the case discussion. And we hope you can get everything you want from us. We have many experienced lecturer and vascular surgeon all around Thailand to be with us today. Tomorrow you will be in the hybrid operating room that you can have a case to study and a demonstration for the instrument. We would like to thank you for the industry to support us to have this meeting like Medtronic and Nova Health. Thank you very much, and I hope you enjoy today's meeting here in Chiang Mai University. Thank you.
Before we start, I would like to invite Associated Dean Professor and also honored speaker to take a picture in front of the meeting room. For today, we have many experts, includes of Dr. Veera from Maharaj Khorat, Dr. Vitawat from Prince of Songkla University, Dr. Kiatisak Hongku from Sirirat Hospital, and also many honored speakers, includes Dr. Watanakit, Dr. Supong, Dr. Titinai, and Dr. Veerapat. So the first session, we will receive a talk by Dr. Vitawat in the topic of rationale for PMEG, bridging the gap on complex aortic care.
Okay, good morning everyone. Thank you Chiang Mai team for inviting me, and thank you Nova Health Belly for the privilege to be here together. And welcome all friends from the Southeast Asia. And today my topic is the rationale for PMEG, bridging the gap in the complex aortic care. In the last 3 decades, EUA has emerged as a safe and valid option for the treatment of the aortic abdominal and thoracic aortic aneurysm. And nowadays, EVA could be considered as the first line treatment for most patients with flexible anatomy. However, we have to deal with patients who have complex aortic anatomy and pathology. Challenge arises when the aneurysm involves the visceral branches with insufficiency normal segment of the aorta to provide aneurysm sealing without excluding those vessels. This requires the surgical intervention or complex endovascular that involve the branching vessel. The challenging aortic aneurysm, including those with the hostile neck anatomy, such as juxta, pala, and suprarenal aortic aneurysm, represent a significant clinical dilemma. It has been reported that approximately 30 to 40% of the infrarenal AAA has insufficiency neck for a standard EVA. Or the thoraco-abdominal aortic aneurysm that need to long coverage visceral artery and spinal cord blood supply involvement. And in aortic dissection that we have to deal with complicated from the dissection, rupture, or deal with the small lumen or the malperfusion. And in infected aneurysm that we have to deal with the infected weakening aortic wall. Treating the complex aortic case poses a significant challenge for the healthcare professional because the anatomy has extensive disease involve visceral artery, need high technical procedure and high risk of the complication. And look for the endovascular strategy for the complex aortic aneurysm. The complex EVA can differ from one patient to another depending on the anatomy of the aneurysm. What option do we have? Start with the commercialized device provided by industry. There are custom-made device and also off-the-shelf device. And we have parallel graft technique and physician modified endograft option that we will talk in the deep detail today. A custom-made device is a personalized patient-specific stent graft engineered precisely to match an individual unique aortic anatomy. Key structural features of this device include the fenestration, scallop, and directional branches. The fenestration is involved the precise custom cutting of hole into the fabric skeleton to ensure direct alignment with the renal or mesenteric artery. The anatomy requires an infrarenal aortic length of at least 4 mm and a distance of less than 5 mm between the aortic wall and the stent. That is why it is useful in the juxtarenal and the pararenal aortic aneurysm. And by the technique, it needs the positioning require both longitudinal and rotational alignment of the graft hole to the target vessel. Misalignment can lead to the vessel occlusion or shattering. And the next one is branch technology. It consists of the small branch fixed to the main aortic stent. It will help maintain circulation to the target vessel without leaking blood outside the stent. The outer and the inner branch design each have the distinct anatomical criteria, such as an aortic lumen greater than 24 mm and specific angle that must be met for the successful implementation. It is used to treat the pararenal, suprarenal, thoraco-abdominal aortic aneurysm and also post dissection also. The advantage of this custom-made device is a perfect anatomical fit tailored specifically to the patient anatomy. It also offers decreased of the aortic coverage, limit the unnecessary aortic cover, and reduce the risk of the complications such as the spinal cord ischemia. However, it still have the limitation. The limitation include the manufacturing delay with a product time of up to 6 to 8 weeks, which cannot use in the emergency or the rupture cases. This waiting time it get rid of the aortic rupture for a symptomatic patient. Additionally, the high cost make it generally more expensive than off-the-shelf or other modality. Next, the modality is off-the-shelf multi-branches device. It uses commercially available pre-manufactured stent graft rather than waiting weeks for custom-made device. There are 4 devices from the 4 companies in the market: the Artivion, Gore, Cook, and from the China. But in Thailand, in Thailand we have only 2 devices, and I think in the future the Gore will come soon. We have the inner branch with pre-cannulate EN site from Artivion and the outer branch T branch from Cook Medical. There are some slight detail different in design, delivery system, and the deployment technique. The advantage of the shelf, it provides the immediate available, which can use in the urgent or emergency cases. And their standardized uniform design allows surgeon to operation consistent planning and implantation technique. The limitation is have the IFU that it may not fit the unusual vessel size or complex aneurysm shape of the patient, and it often requires more extensive coverage of the healthy aorta than the customized graft. This is the increased risk of the sacrificed vital side branch and less the risk of the spinal cord ischemia. It is the proximal length. That means when we use the off-the-shelf, it will be covered maybe at least 10 centimeters above the celiac. That may get rid of the spinal cord ischemia. And the next one is the parallel graft technique. This technique described by Ron Greenberg in 2003 the technique is based placement of the stent parallel to the main aortic stent graft, extend the proximal ceiling zone over side branches while maintaining patency to those branches. It can deploy in several different ways. The chimney or snaggling, bring it down, and the periscope technique, reverse chimney from the femoral axis, or the sandwich technique. It is primarily used as an off-the-shelf alternative of an off-label bail-out procedure in Europe. This technique specialized parallel graft component have achieved the CE mark approved for the chimney indication. It is reserved for the high-risk patient with complex or jugular renal AAA. Follow this IFU anatomical criteria that can use in the short neck, angulated, and renal angulation. For the short neck, they need the infrarenal neck more than 2 millimeter, and the planning get the new neck zone more than 50 millimeter, and the suggestion the chimney should not over 2 chimney. And the sandwich technique described by Loreto in 2011. This is used for the treatment of the thoraco-abdominal aortic aneurysm and the iliac aneurysm by the sandwich technique. In this case, you will see it had some limitation. It had the stent graft for the aortic and the side branch. This is some limitation. And the advantage, this modality offer the immediately availability with the standard device, make it highly vulnerable for emergency. And it also provides unique intraoperative adaptability for the complex anatomy challenge. And it is the technique is quite more easy when compared to the another modality. But however, the limitation is the gutter leak. This is the Achilles heel for this treatment. It makes the type 1 endo leak in the future. And however, it still have no universal consensus on the base type of the stent graft component. Look for the physician modified endograft. This is our topic today, what we talk to in the deep detail all the day. PMEG are currently part of the armamentarium of most center treating patients with the complex aortic aneurysm. You will see this is the cross-sectional global survey. In case this quite unfit for the open repair in the patient who had the emergency or urgency cases. Like this one, this is the symptomatic complex aneurysm with large aneurysm, jugular with complication like this. In the green bar is the proportion of the PMEG. You will see the blue is of the shell. You will see the proportion allow 1:1 is the PMEG used in this situation. And the PMEG will help to fill a gap of clinical need in center without the access to the commercially available device. And in some case, I think it will show PMEG had better suit than of the shell device or CMD to optimize design and the aortic coverage to the need of the patient. And look for the history a little bit. Since the early 1990, the treatment for the complex need more develop more complex procedure. The timeline of progression of the development of fenestration and the branch stent graft using modification. First case report from the Korean doctor. They make the fenestrated hole on the homemade endograft. Treat the patient, try keep the IMA and the renal perfusion in 1996. And after that, in 1997, the report from the Perth doctor, Australia, demonstrated the successful deployment in the fenestration in the animal model. And the next year, performed the first fenestration endovascular aneurysm repair using the bifurcated Cook platform in the human. And after that, the development is more and more. They change to the modify on the tilt graft and separate with the bifurcated graft over the Cook platform and evolve to the Zenith Fen by Cook. And parallel innovation in 2000, the team shooter report their first multi-branch TAAA repair in cooperating all four renal and mesenteric artery with directional branch and was the prototype for the current of the shell T branch now. And until 2006, the PMEG was reported first in the single 2 fenestration and 4 fenestration PMEG in the United States. And after that, Benjamin Starr introduced term of the PMEG to describe the modification made to the commercially available aortic stent graft and get FDA approved investigation device to treat the jugular renal AAA. And after that, the various techniques for the endograft modification have been developed, including the diameter reducing tie, reinforced fenestration, directional branch, mini cuff, inner branch orientation marker, and stent start relocation. This modification has been refined and expanded to the other manufacture in the field, like from the core, the terumo, something. And the technique has developed more and more therapeutic application to treat the juxta, paralinal, TAAA, and also include the arch pathology. In the experienced hand, PMEG has a good outcome with a high technical success rate, around 97%, acceptable major adverse event, low the 30-day mortality rate around 4.4%, and an acceptable major adverse event and re-intervention rate. Before undergoing the PMEG treatment, of course, PMEG is tailored to each patient. Therefore, the planning is key to success. We must be able to accurately assess the patient anatomy, meticulous planning and sizing, evaluate the aorta and target vessel, ensure the correct positioning of the fenestration, choose the endograft that use the modify, adapt the technique of creating PMEG to the specific need of the case. Some cases need the fenestration or need the branch configuration. Dr. Kitisak will provide the further detail on this step. The next step involves the modify the endograft by preparing equipment on the back table. Dr. Chathorn will give a talk and share his checklist of equipment for the modification again. And the process of the modification include de-sheathing, marking the position of the target vessel accurately, creating a fin or branch, and creating diameter reducing tie and re-sheathing. I think Dr. Watanakit will demonstrate the manipulation of the endograft during the creation of the PMEG with the exceptional hand-eye coordination in the next section. And the next one is the endograft implantation. The endograft implantation is a crucial to meticulously deploy the device. Additionally, having the ability to manage any intraoperative complication requires great experience and calmness under pressure. Dr. Vila will show us how to deploy the endograft and solve the problem intraoperatively again in the afternoon session. And post-operative care is very important. Lifelong monitor to check the integrity of the stent graft and ensure the aneurysm is not growing. And in conclusion, for the treatment of the complex aortic pathology, open surgery remains the gold standard for the low-risk patient, while the complex endovascular procedure are an option for the high-risk patient. There are multiple modalities available, each with its own advantage and limitation, which no one fit for all solution. PMEG may be a promising alternative modality that can address the limitation of the other treatment option. However, it has not standardized now. The safety, technical success, and the durability of the PMEG heavily depend on the surgeon's high level of back table skill and extensive training. Thank you and enjoy.
Thank you, Dr. Vitawat, for your lecture. I have a short question for you, Dr. Vitawat. Please on the podium. I have a short question for you.
Please.
Okay. In your daily practice, when you consider off-the-shelf device, when you choose the outer branch, or when you choose the inner branch, and when you choose the PMEG in your practice?
In our practice, luckily in our center, we can access for the off-the-shelf and PMEG also. In the you mentioned on the elective or emergency. In emergency, if we although we have the off-the-shelf, but I'm not in Bangkok. We don't have stock in our hospital. We prefer to do the PMEG first. Because of that, I mentioned we can design and not too long the coverage. Because of the shell, it is the weak point for the off-the-shelf. The off-the-shelf is good device, but it's still the standard that it has the long proximal. It will be the more proximal coverage. The proximal. I don't have experience, but that I mentioned in Thailand we have the two devices. The first one is the inner branch from Aortic, but the inner branch from Aortic is had the pre-cannulation with the preload catheter inside the stent graft. By the technique, I think if you would like to cut the proximal, we can do on board platform, even from the Cook or the Artivion. But I did not get the experience about this technique yet.
Thank you very much, and also thank you CMU team for a very kind invitation to join this session. Here is my topics, and as discussed with Dr. Chayathorn, the sizing part will be covered by many speakers, so I will skip that, and I will just review the anatomies and also the device characteristic that we will choose to match with the clinical need in our modification of the stent graft. This is one of the studies that show the popularity of the PMEG right now. It's a national consensus for off-label treatment with to treat the complex aortic aneurysms, and you can see that a lot of a big proportion of the PMEGs is chosen for many doctors. And because this is a study conducted in US, so you can see that some stent graft will be the Cook device that is used by a lot of experts in US, and then they modify the stent graft. So the popularity of the stent used mostly by the Cook company. But you can see that many modification. This is for the laser in situ fenestration, so they use a lot of various platform. But the factors that determine the choice will be the familiarities, also the anatomical specific factors, and also the logistic issue like availability of the products. But this is a device platform that we can do the modifications for thoracic device. Mostly, I think right now we use a Valiant Captivius, and some of us who use Sinit Alpha and also Sinit TX2 dissection stent from Cook. And I think some colleagues in Vietnam, they modified the relay from Broughton, and our colleagues in Thailand, some of them modified the 3G from Artivion. For the bifurcated graft, mostly we use trios and also endolant stent graft, and also some case we use a Cook device. Iliac limb, mostly we use the endolant limbs, and also some miscellaneous device like AUI or abdominal tube, or even off-the-shelf device can be modified also. Let's start with the thoracic device. I think the advantage of the thoracic device, as we know that we have a large strut, and also we have the wide fabrics that we can place a lot of fenestration that can fit it well, and also the length is also long enough to cover, and most devices have no barb to be concerned. But the concern of the thoracic device is because of the large strut and also a lot of fabric. So there will be less conformability to some kind of pathologies. And also the length itself, not just only the advantage. Some of them can be disadvantage because of too much coverage. And maybe the risk of spinal cord ischemia. And also problem of the device, also it has a large profile, mostly about 22-24 French on the off the shelf. So will be some problem in Asian populations. First of all, the thoracic variant device, we have a large strut as we discussed earlier, but in this device have a relatively short gap between the strut. We have no barb. That means the short gap is flexible enough, but also stable enough to do the manipulation. You cannot twist the graft easily, because if you have a gap and you have a fixed deployment of the stent to the wall, when you turn the graft, you probably can twist the gap. So this can be one of the advantage. It's stable enough to be used as the PMEG. And also we can access from the top because they have an open access, but it will be through the base stent. We're not at the central lumen of the graft. The graft have a straight graft, and also they have a taper version of the 4 mm tapering stent. The taper stent starting from the proximal diameter of 26 and have only, let's say, only one length, about 150, but mostly about 150 to 160. It depends on the diameter of the stent. And this device will be in large profile 22-24 French. The next one is thoracic alpha from Cook. Also have a large strut, also the large free fabric too. That we can place the fenestration or the branch, but the problem with this one is have a wide gap. It's very flexible, but so it can be twisted easily when we turn the graft too. So it's less stable platform for manipulation, and especially when we don't have a tool to control, let's say like diameter reducing tie or something like that. And they have a fixation barb on the first sealing stent that we have to cut it out when we resheathing, because it's reversed. When we resheath it, it will catch up with the barb. And this is have a 4 mm tapering stent starting from 30 mm diameters. But they have some few lengths available, 109 for the 30 mm tapering graft, and mostly about 150, 160 for the version that we use mostly. And in some specific case, they have 200 and more for the tapering stent. This is the first stent that we used many years ago. We used a dissection stent. It's based on the TX2 platform of the Cook. It's stainless steel, but the problem is that have a narrow C stent, and it's difficult to place the fenestration, especially when you try and you have to do many fenestration, let's say 3 or 4. It will be very difficult to set it. But we can modify the strut sometime, but it distorts the stent also. They have no fixation on the dissection platform, but if you use a TX2 as a thoracic one, they have a barb with a fixation barb to be careful to select one. The most important advantage of this device, they have a double taper of the 8 mm diameter taperings. Starting from 32, they can down to 28, 26. And this is have a very important part in some case that we need to aggressive tapering the graft. But the profile should be very large because it's old version of the device. For the bifurcated abdominal device, I think the advantage is when we perform the PMEG with the bifurcated graft, we use less component. We don't have to extend with the bifurcated component that You know, because we do the PMEG, we don't have a specific bifurcated platform, so we have to modify some of them. Let's say we cut the barb or we use the barb, but we risk for the type 3 endoleaks from the barb injury to the bad stent from the thoracic stent itself. So, and also when we don't have to connect with the bifurcated, we avoid the risk of the type 3B overlap endoleaks, and this will limit the coverage of the aorta. But the concern is that when we deploy the rims, also when we all have to open the contra limb, it will be difficult to resheath it without twisting the graft. And also some of them still have some difficulty in placing the fenestration. I think the first one, and right now is my favorite one, is the 3O stent graft. Because you can look at the image that the 3O itself, the body itself look like a thoracic device. They have a wide base of the stent strut and have a lot of free fabric to place the fenestration. And also the most important thing of the 3O device, you can, Dr. Witwat mentioned that is the first stent that has been on the IDE trial in US for the two fenestration, but it is very important that you have a very excellent proximal clasping of the device. You can even twist the proximal part and distal part in the different way. You can control it, even you open it fully. And you can access from the proximal aspect to it don't crash and don't crimp the proximal graft completely. It's to be open like in the picture, in the picture like this. And the another important thing is they have a long body version. They have 120 from the top graft to the to the contralateral limb. That means you have around 90 mm trunk, and it will coming in 140 because this one was approved for the PMEG set. They call the Aortic fit. That have a set for the fenestration as a design by the AI and also the planning platform, and they send that set to you, so they will come with a longer body of 140 to cover more aortic territory. The profile itself is quite small. It is quite interesting to have 18 or 19 French totally for the fenestration, and this come to the 3O fenestration. That means commercially available fenestrated graft with this platform. So it's very small compared to the available customer device. It densely packed, so it will sometimes if you put some component, let's say fenestration or the branch, it will be difficult to resheath it completely. And if you look at the flushing mechanism of this device, the flushing port is here. You can see the mouse here. And when we deploy it, so the handle will cover the flushing port, and sometimes that we cannot completely resheath it, so the flushing port will be not exposed and will be cannot flush it later after incomplete resheathing. The next thing is the endurance stent. You know already for this device. The good thing is that they have very flexible. You adapt to many challenging anatomies because of asymmetrical stent with a little bit not large free fabric, but you can find some place to place the fenestration. It also have a well-controlled superior bad stent control mechanisms, and the profile is acceptable for 18 to 20 French. And if we would like to modify the bifurcated endurance graft, I think I myself prefer to use, I rarely modify this one, but when we helping the case, I mostly suggest to use the endurance 2, because you still have some IPSI limb inside the sheet that you can control the graft. Because if you use the endurance 2S, when you modify it and you place a stent, when you try to turn to navigate the fenestration, so sometimes it's accidentally release of the IPSI limbs and you cannot control it at all. So also it's a well-engineered and densely packed device. The next one that I used to do that, Sinit abdominal alpha, but I skipped doing right now because this is a laser cut and an retinal laser cut. The first bad stent, the bad stent and the first saline stent is the laser cut. It's like a retinal plate that you cut it to be a stent. It's very strong. And when you deploy it outside, it fully expands. You can clamp it back to resheath it, but it will not go back to the one that original in the sheath. So in this case, I think the only case that I did the modification for the abdominal alpha because when we deploy it, it causing with the infolding of the graft like a Pac-Man because of the small aorta that we plan to do the fenestration on this area. The good thing is to have a various length of the bodies, also quite similar to the trios, and is very small. And the Cook device itself, it's relatively loosely packed or loaded in the sheath because they have to spare some space for flushing and for the gas to do the sterilization. So compared to other device, I think Cook device is a bit easily to resheath it. The next thing is the iliac limb. I think most of us, we know Dr. Chan Chao also use a lot of iliac limb to do the fenestration or the branch for preservation of internal iliac artery. And this is a fixed proximal diameter of 16. It's good enough for the overlap. You can see that a lot of version of the limb that we have, but the tapering part, if it's tapering to 16 to 13 is not too much difference, so it need only 10 millimeter or 1 centimeter of tapering. But if you taper down to 10, it will be 2 centimeter of taperings. And the B is an external limb that we replace, mostly when we use for the eye or for the iliac preservation. I think in our Asian population, or even when we have a common iliac artery aneurysm that we need iliac preservation, some of them we place faced with tortuous or short external iliac artery. So the version that should be available or used for fenestration or branch will be only the length of 82, 93, or even 124. That will be much more space for proximal overlap in case of you have a long anatomy. But one of the things that we can use, and I sometimes use it for abdominal tube graft, is iliac extension. Because you have a 20, 24, or 28 mm tube extension, the length is 82 is suitable for infrarenal, so I use sometimes for some infrarenal pathology like a saccular aneurysm. And the good things of the device is very well conformed to the anatomy, so it have less infolding compared to the same size of the similar dimension or length of the thoracic device. Then the last one is the AUI or abdominal tube, some miscellaneous. This also we have sometimes use the AUI platform in case that we deal with the distal small aorta, and also the trios, and then has similar configuration about 100 mm total length, and distally around 13 or 14. And this is let's say it will create some space outside the distal portion of the graft that have been tapered, so we can place some branch also. And this is an off-the-shelf device that we can modify, because as Dr. mentioned and Dr. Vitawat mentioned that we have this one available, the Cook device and the Synet T branch. But the problem is you have to cover at least 10 or more for the Aortic coverage, and it will be too much for some pathology like juxtarenal or pararenals. And you can modify it, but let's say that you modify, you cut it, but you cut the opportunity to proximally extend the graft in the future. So this will be just only for some special case of juxtarenal or pararenal that you can look at the thoracic aorta and disease free. You don't need to extend it later, otherwise you create some problems in the future. You can cut the proximal or distal. It depends on the length which you want. So the proximal one, you can cut to limit the aortic coverage. And distal one, you can cut to accommodate the short infrarenal length. And also it comes with accompany unibodies that you can also cut it out, or you can modify the limb, cut it and place it like an inverted contralateral limb to limit in the limited short infrarenal length to overlap with the T branch. So come to the anatomy specific consideration. So when we discuss with the complex aortic pathology, so the proximal landing zone should be only at the supraciliac aorta, and also sometimes we just seal across the visceral artery, because by definition of the pathology, the aortic segment between the renals and the SMA should be healthy enough to seal. And in some pathology, like say type 4, it will be the sealing part at the supraciliac artery. Distally, mostly because of this one involved abdominal aorta, so mostly we have to cover down to the iliac artery. For thoracoabdominal pathology, mostly we have to see in distal, the descending thoracic aorta, except for the type 4 that we mentioned earlier. But the distal portion, it can be in abdominal aorta in extent 1 and extent 5. It depends, and also mostly we down to the iliac artery. Looking back to the anatomy of the visceral artery, when we look at the plan that we get from experience from planning with the custom-made device, I think when you look at the fenestration of celiac artery and the renal artery, the lowest one, the range of the spatial distance is around 30 to 40 to 50 mm. Mostly fall in these regions and we like a cluster of the visceral artery. So when we look back to the anatomies of the pathology, let's say juxtarenal and pararenal, that we think that we should seal across the visceral artery. And if we use the graft for thoracic device, I probably select a straight graft of the 100 mm, because you can cover all for fenestration or for visceral artery with the remaining enough, nearly half of the graft for distal overlap. And mostly the infrarenal length in Asian population around 80 to 100 from the renal artery to the aortic bifurcation. So the 50 mm should be reasonable for distal extension with the bifurcated graft. But if you use the thoracic device to treat the thoracoabdominals, so that means you need the proximal sealing above the visceral artery or the overlap with the proximal TIVA. So the cluster of 5 centimeters of the visceral artery can be placed at the middle of the graft. This is just to allow proximal overlap safely with the proximal TIVA or get the secure proximal sealings, and also leaving the distal part of the graft for the overlap with the bifurcated graft extension too. So this is a reasonable use of the taper graft. But if we use the taper graft for the low extent of the aneurysm, let's say juxtarenal or pararenal, that we know exactly that we should seal around the visceral regions. If we place the graft, the fenestration, for fenestration at the middle portion, that means we have to cover the aorta unnecessarily in the proximal part, let's say around 3 to 5 centimeters more aortic coverage to keep the distal part the same configuration. But if we choose to use that graft and we place the graft correctly proximally, we have to deal with the problem with the too long distal graft to be placed in the distal aorta, and a little bit difficult to put the bifurcated device if we have a long distal part protruding in the abdominal aorta. So the reasonable use and ideal for juxtarenal for me, maybe the long bifurcated graft with the 90 mm trunk, that you still have a room to cover all for fenestration, and also you have some extra room above celiac artery, that you can sometimes skip celiac artery if you're concerned about proximal fenestration. And this will still leave some length above the bifurcation around 1 centimeters, and also 40 mm below the renal artery is reasonable and can be covered with one iliac limb. So this is to avoid overlap as mentioned earlier and less cost of the device. And this is the one that the examples of the use of the long bifurcated device for fenestration PMEGs. This is adaptation of the use of AUI in small aorta, as I mentioned earlier. This juxtarenal paravisceral pseudoaneurysm after the chimney. So this is a modification. We can have a limited coverage above the renal artery or the visceral artery. It depends on the pathology that you're dealing with. In this case, like juxtarenals or pararenals or something, saccular aneurysm, you don't expect the proximal disease progression in the near future. So placing fenestration around this region is to be stable enough to treat the patients. For the iliac limbs, and I think this will cover by Dr. Chan Chao to be a lot of experience for use of iliac limb for iliac preservation as a fenestration of brand. And this is, I mentioned to you earlier about using the limb for small aorta. You can see that in the thoracic, when we open the one without the barb, there's a free flow. The problem that we face is the retroflexion of the graft. It can caused by the windsock effect, but this is quite stable platform because it's short stent, so it can be very, very stable. We use it in saccular aneurysm, and also you cannot have a proximal clasping, so we partially deploy and we can get from above to secure the fenestration. This is a tilt graft, and you can see this configuration. If you have a regular or saccular pathology of the abdominal aorta, you can see the better conformation of the short strut stent along the aorta. And this is also another example to use the saccular, use the iliac limb to seal the saccular iliac aneurysm. You can see this SMA retrosaccular aneurysms, and we place with the one single brand. You can see the protrusion of the strut that conform to the pathology to the neck of the pseudoaneurysm. This cannot be happen with the thoracic stent. And this will be a lot of enfolding of the use in small aorta like this. So this is one of the options that we can think about. This is an example of the use of AUI. You can extend the graft with the various flare limbs or even iso limb to treat and to seal just only in the abdominal aorta. You don't have to place the bifurcated graft in the narrow aorta. So this is an option we can use. And this is end result. So one concern, and you will face of this problem more and more in the future, is the type 1A repair. So the problem is diameter concern. You have to deal with the new proximal seal zone that you have to get the graft in the proper diameters, and you have to concern about existing EVA trunk that have to seal. If you use a tilt graft, the length itself, the short trunk, the trunk of the bifurcated body usually shorter than the original one, because mostly the type 1A happens to the challenging necks or hostile neck, that when you do the graft with the angulation, so the real length that you have later, if you're not as a proximal as the original graft one. So, and the seal itself, it's a problem for sure to seal in a short and angulated previous EVA trunk. So the option right now might be turn the strategy to do the total relining. So this is one will be can be done by the PMEG on the bifurcated body too. Even custom-made device right now, we order the graft on the bifurcated graft to treat all this pathology. And this one is an example of Dr. Ram mentioned earlier, the modify the T branch, because when you use the T branch, you know that distally you have 6 centimeters below the renal branch, and this will be too long to accommodate in the previous EVA trunk. Sometimes we have to cut it out. This is we cut it one stent, and also when we use this one, we have to cut the distal body to cut the unibody one stent, or you do the inverted limb to make a proper seal in that short remaining distal part of the T branch. This is the final results when we use this one, but you can see the extra coverage of the thoracic aorta by this device. So I think in summary, when we deal with the JAXA or pararenals, for me right now, I prefer to use a long bifurcated bodies or even short thoracic stent graft. In case that we need to use a long thoracic bodies, I think this is just in case that we prepare for the proximal extension. For the thoracoabdominal, even for fin and branch, we use a long thoracic device. The taper one will match well. And because of the thoracic device, proximally usually large, if you don't taper the graft, you probably face with the problem to shoot the graft that's available for distal extension. Because of the bifurcated bodies, the largest one is 36, so you have to taper it down. And for the type 1A repair, the total relining might be the option of choice right now. So for me, if we have to repair it with the PMEG, I will use a long body abdominal graft. Alternatively, I will use some modification of the shell device. And also the different properties and advantage and disadvantage of among various platforms is, I think you know that already, and you have to match them well with the clinical needs. And however, this is depends on the suitability of the anatomies, familiarities of the stent graft that you have, and also the logistic feasibility that you have available stent graft in your center. Thank you very much.
Hello. Thank you, Dr. Kirtisak, for complete lecture about the PMEG. Any question from our speaker or participant? No question. I know you don't like to use the preload wide or diameter reducing time, but in your condition, when you consider to use the diameter reducing time and preload wide?
Initially, I did it all the case, but I think when you do that, you will see that in some case, when you're doing the case, I think this case why we have to play the preload why, something like that. So right now, I think one consideration to use the preload system, to use the preload why or catheter is the inner branch, in some challenging inner branch, because right now inner branch we place the reinforced ring at the orifice of the branch, so it became easier to cannulate the branch but without the preload wire. But in some challenging anatomy that you really need to get into the branch, let's say small aorta, it can be compressed, so the preload one we will provide you the way to the branch directly. So it will be one of my options.
Okay, and thank you. The second question is, do you prefer the approach from the upper extremity first, or do you prefer from the ploy first?
For me, I think upper extremity access is not the sin, so we can do it. But lately, especially when you do it for the emergency case, you would like to do more from femoral because you can control it. You can do it from using only the local anesthesia. So in challenging anatomy that we need the very good positioning of the graft, I still have upper extremity access, maybe smaller than we used before. In the past, we used 12 French sheet, right, to do everything from the arm. But right now, if you just concerned about some important target vessel, so maybe only 6 French or 7 French to cannulate and fix the position of that branch. So after that, you can release the whole graft and you do the remaining things from femoral artery. But in the case that you place the diameter reducing tie, or you can control the graft properly, so you can rely on the femoral access solely.
And the last question, when you approach from the upper extremity, which side, right or left or both, that you prefer?
For me, almost always right, unless the disease arch. So I will look at the arch first. If the arch we have plaque at the innominate artery and the mid arch, the transverse arch with some disease. I will from the left, but this is not routinely, because if you look at the left subclavian artery, probably you have disease more than the innominate artery. You can see some stenotic disease of the proximal left subclavian artery. So it depends on anatomies. We look at the arch carefully. So that means when we do some kind of this disease treatment, we have to evaluate all the supra aortic trunk too. This will provide us more information, but mostly I come from the right because I have, let's say, easier positioning of the C-arm, of the assistant, of the operator, that will be more ergonomic.
Okay.
Okay, I have one question. When we do the PMEG, the some problem is when we have to cut the PMEG, the strut is on the fenestration, but when we use the thoracic, we can manage that. But in your lecture, you use the endurance limb, and as we all know, the strut is more narrow. So how could you manage when you're planning the location of the fenestration and the strut is on the way?
You can see that only 2 fenestration or the branch that I accept on the iliac endurance limb, because that limitation. So, but if you have a problems of the positionings of the fenestration, probably you fix with one fenestration and the other one will be branch. That will be more flexible and give you more room to do the operation.
Do you have experience with to cut the strut of the stent, because to cut the strut because of the fenestration is not perfect?
I think that happens on my second or third case of fenestration. I cut the ring just to place the fenestration, and that caused me some problem of the collapse stent and incomplete support of the ring. But I think removal of the strut is not the bad idea, because if you look at the new platform of fenestration, you can even place on the strut-free portion of the graft. Probably you can remove the whole things.
Okay, thank you.
My question is that I think it's a big challenging to deploy a PMEG in small aorta. Have you can provide any, pinfall technique if you miss the penetration orifice when you open up the stent, or any backup plan if you already miss the orifice? Like using the angulation sheaths to do the laser puncture, something like that.
I think that the bail out of the report, the bail out to use a laser in situ laser fenestration. But as I mentioned earlier, if we think that we will face the problem of deployment, or in some challenging anatomy, let's say angulated necks or something, or narrow, that you cannot control the graft properly, my preferred strategy is to do the partial deployment and get access from the arm. That means a lot of
so you partial deploy and then you start cannulation for the upper extremity. Okay.
Because you still keep most of the graft inside the sheath, you can control it. You can pull it back.
Or maybe you can suture a constriction ring for
No, just let's say deploy until the fenestration exposed, and then you come from the arm, cannulate that fenestration, do the cannulation of the branch, and then further deploy the graft.
Okay, so deployment approaching for the extremity is always the way you can manage to cannulate. Okay.
Yes.
Thank you.
You can do it one by one, even complete the fenestration stenting.
Thank you. My name is Iza from Indonesia. I want to ask about the small diameter aorta, because in my opinion, in the small diameter aorta, we put four fan with the 6 or 8 millimeter big graft inside the small aorta. Will it disturb the flow of the aorta or not? And the second question is, there is any contraindication for you when we cannot do the PMEG, whether it's about the diameter of the aorta, the angulation of the aorta, or etc.?
I think this is happen to all the device, not just for the PMEG. So when you're concerned about the small aorta, my cutoff is around 16. So I think 16 is just enough. I mean that's too small to place many fenestration. But it depends on anatomy too. Let's say the large case they show you the juxtarenal or the sacula on the behind. The remaining lumen is just 14 or 12. But you know the pathology of the sacula that will be treated and they will be expand later. So I choose one reason that I choose the branch is just to protect the lumen of the aorta. I don't want to make some protrusion of the stent inside the small aortic lumen. You may have some problem just starting the deployment. You cannot pull the nose cone down because of that fenestration. So that will be a problem. So I will reluctant to do many fenestration on small aorta. My cut point around 16. Smaller than this, some consideration to other options. And the second question?
The second one is there any anatomical challenge that make you cannot do the PMEG? Either the angulation, the diameter, or any other anatomical?
I think for me, the most important will be the angulation, especially combined with the fecal access, because you cannot control anything at all. So in that situation, I prefer to do something else. Or if we have to do the PMEG because of urgency of the case, I have to add up some adjunct, let's say diameter routing tie or preload that system and do the partial deploy. Come from the preload one, do the fenestration and further deploy, something like that. So you have to add up more technique to deal with difficult anatomy.
Thank you.
Thank you, Dr. Kietisak. And the next speaker is Dr. Sherathon from Chiang Mai University. He will talk about bent top setup and tool for preparing for the graft modification. Dr. Sherathon, please.
First, I would like to thank you all of the speaker and all colleagues that joining us our workshop today. And also, I'd like to greeting to the participant in the Zoom, around 50 to 60 participants in the Zoom. I do apologize for the Zoom meeting that we can't do the two-way communication, but maybe improve after this. For my topic for today is the benchtop setup tool preparation for modification. Before I start my work, I would like to introduce my center a little bit. Our center is the Chiang Mai University, and we work together with a large hospital in the same city, Nakhon Ping Hospital. We work as a team to treat complex aortic cases. And I have a good chance to learn from Dr. Kietisak, Dr. Vira, and Dr. Vitawat. And for now, I produced my own technique. So far, this is our outcome during 2 years past. Around many cases of the PMEG start with the modified endurance limb, and we move up to treat the thoracoabdominal pathology and also on the arch. And this is my published work on the modified endurance limb. So I will give a talk followed by this outline. As we know that the PMEG success begins before entering the operating room, because if we have a good planning, sizing, and also good preparation for back table modification, will lead us to have a successful during the PMEG operation. So bent top preparation is one of the crucial steps for the PMEG. The challenging thing is that the PMEG is the technically demanding and also still don't have the standardized workflow. If we can establish the standardized workflow for your center, it will reduce the modification error, the procedural time, technical failure, and make a short learning curve. And others doctor can follow the same step. The previous published paper was published by Dr. Michel Piesa. He described the standardized technique approach for full fenestration in pararenal and juxtarenal aortic aneurysm. his published work said that he measured above the celiac level around 5 centimeter and used the posterior diameter reducing tie, used the egg marker to do the S marker in the PMEG. And there also the report of the outcome by use the standard die approach. The technical success is quite high and less mortality and also the major adverse event. Another published that was reported is to use the punch card technique to make accuracy during modification of the graph. But in Asian country, we do more and more PMEG things, but still don't have a standard die approach for Asian population. And many center has a high volume of the case. And I think one of the people that simplified the technique in Thailand is Dr. Virat from Maharaj Nakhon Ratchasima. After he established his own technique and teaching more and more in many center can do PMEG. I think in near future we will be do the standard die approach for Thailand and maybe for Asian population. So before we start the on-table modification, we should do the accuracy of the measurement first. As I show in the slide, we do measure twice, modify once. Mean we have to recheck again and again until get the actual correct measurement before we start to modification of the graph. The things that we have to learn is to use the software like Trimensio, Aortic, Horos, or any other platform that you can do the 3D reconstruction, centralized generation, and evaluate for the aortic anatomy. The first one software is the free software, include Horos and Aortic. And the Trimensio is one of the expensive software, but provide us many tools during the measurement. For me, I use the Horos system and start with the 3D curve MPR. We have import the thin cut CT and use the axial view and start the 3D curve MPR for generate the center line. For pararenal and juxtarenal, I will start measurement from 5 centimeter above celiac level, but for thoracoabdominal or arch pathology, I will move higher to get better sealing. After we do the red dot for center line generation, like this picture, we start to measure the distance between the visceral branch. Mostly I use the center of the celiac level and down to other branches by use the center point to measure the length between each branch. Some surgeon like maybe Korat, I think Dr. Virat used the lower edge of the celiac and down to other branches. But in some center use the SMA as the reference. It will not quite different in the straight anatomy, but it will affect when you measure in the angulated anatomy. For me, if we meet the angulated anatomy, I will compare the center line and outer curve and lesser curve length for adjust the position of the fenestration. And also if we meet the challenging anatomy, we will plan for do the inner branch like Dr. Ketisak mentioned. After we measure for the length between each branch, we will use the we will measure the branch orientation by use clock position or opening angle and then convert it to the arc length of the visceral branch. Like shown in this picture, we measure the angle from 12 o'clock and to the opening of each branch and get the angle of that and calculate for the arc length. This is the example that we use to calculate the arc length, and this is the equation for calculation. We convert the diameter of the graph into the 360 degree and then we calculate for each angle should be multiplied to the angle of the branch. And most of the case we use the SMA as at the center of the endograft and we will minus the SMA angle first and multiply by one angle of the branch opening. And then we can measure the arc length like this. After that, we do the final plot for the PMEG before start the modification. Mostly I use the simple paper and measure from proximal 5 centimeter in the para or juxtarenal and start do the fenestration. And SMA is the mark point for measurement, and then measure to laterally by use the arc length that we already calculated. And this is the final plot for the one PMEG case. After we measurement, we do check again and again with the cell ref and also other doctor that include in that operation and prepare for the back table step. The back table step start with prepare for the general operating room instrument. We need a long sterile back table for graft modification, and simple instrument include clamp, forceps, conservator needle holder, and sterile ruler and fine marker for making the fenestration plot on the endograft. Some surgeons use the electrode cautery to cut the hole for the fenestration, but for me I use the only simple scalpel to cut the fabric. And we plan for the endograft platform that already talked by Dr. Kiatisak mentioned. We have many kind of the stent graft, and we have to select to match to our patient anatomy. After we create the fenestration, we use the reinforcement around the fenestration by use the double loop snare. Mostly we use double loop snare because it's good opacification. If you don't have the double loop, you can use tip of the stiff wire or micro wire, or some surgeons suggest to use the coil to do reinforce around the fenestration. This is the table that compare the difference between the reinforced around the fenestration. First one is the tip of stiff wire. You can see that it's quite good during fluoroscopy, but it's quite bulky and large ring. When we resheath, we will meet some problem if we do more and more fenestration on one with the stiff wire tip. And this is the double loop snare that I mentioned. Most of the case I use this one because it's good flexibility and also good to see in the fluoroscopy. And after we deploy, it will come back to the oval shape. The micro guide wire tip is we can also use if we don't have any other things, but it's less opacification that I will show you in the next slide. You can see that in this case, I use the double loop snare for the proximal part and micro guide wire in the distal part. This picture was done by Dr. Krista from Nakhon Ping Hospital. And you can see that the double loop snare is easier to see in the fluoroscopy than the micro guide wire tip. The next equipment that we need to prepare is the prosthetic graft, maybe PTFE or Dragon graft if you want to do the inner branch design. And as mentioned, most of the case we didn't do the preloaded wire, but in some challenging anatomy we have to insert a preloaded wire. We can use 035, 018 and 014 guide wire. Mostly I use 018 guide wire because it's smaller and has a good support for follow the long sheet or balloon inside. But in the case that we need to put more than 1 or 2 preloaded wire, we skip to use the 014 guide wire because it's thinner. But for the arch pathology and I do only single fenestration, I tend to use the 035 guide wire. And when we do the preloaded wire, we need to puncture to the delivery system and it will cause some bleeding, so we have to wrap around the hole that we already punctured and to prevent the bleeding like this picture. And after that we put the things back to the delivery system, and Dr. Watanakit will give some detail on this technique by use many kind of instrument. And this will presented by Dr. Watanakit also to do the fenestration or inner branch, which case that you select to do the fenestration or which case you should select to do the inner branch design. So far that I talk many things about the benchtop preparation. This is my checklist before start the operation. We have to check our planning twice and prepare for the basic surgical instrument before start, check the endograft and the modification that we need to do. This is my checklist, so you can use this one before start your own PMEG, first case PMEG. This is the step for the back table preparation, so I will move this one fast. We start with deployment the endograft and secure the proximal part to prevent it pop up. And this is my way to plot in the endograft. First, I do the transverse line for the length between each visceral branches and then use SMA at the egg marker to set the 12 o'clock and use the arc length for plot to the other branches. And after we finish drawing the plot on the endograft, we do the fenestration or inner branch and reinforce around with double loop snare. We can use O5O proline or CV or any other things like Tricon or any other suture material that suture around the double loop snare. You can use the continuous lock or continuous suture to suture around. And then if need, we push the preloaded wire. Like in this case, we do the inner branch. You have to avoid the strut of the proximal part and just place the preloaded wire between the bare stem of the variant platform. And this one reported by Dr. Vira to use the proline circular encircle reducing tie. The final picture of the modification graph will be like this. The fenestration located here, and this is the proline encircle reducing tie, and then we put it back into the device, and Dr. Watanikit will give us a detail on this. During the benchtop planning and the back table modification, we will meet some problem like incorrect measurement, and it will lead to the disaster or something during the operation. So we have to check twice before start the modification. And if we cut larger hole for the fenestration, we can only do the ring at the same diameter of the fenestration that we already made, but during the procedure we have to flare more in the fenestration. And if the reducing tie is break during we resheath, we just apply a new reducing tie. And as I mentioned, you have to avoid wrap around the delivery system of the preloaded wire. If it's occur, we have to realign it again or maybe remove and insert it again. One of the things that will occur during the resheath is the something bulky than the old delivery system, and we can't put it back into the same delivery system. We have to recheck again that we can we crimp more and just put in the same device, or need a larger sheet to recap the bulky part. Or if we still can't do anything, we have to just cut the branch out and leave only fenestration and accept the bell out things. So for my talk, this is the back table checklist, and I will give another talk in the intraoperative step, and I will give you this one, the checklist for intraoperative again. For my conclusion, I think successful in PMEG, as I mentioned, is will start before we do the operation. Measure twice, prepare the equipment first, and prepare for the all bell out plan. And for me, I think learn from experienced mentor make me more confidence to do my own PMEG step, and also build a strong team between each hospital, and also maybe for cardiac surgeon, for vascular surgeon. Thank you for your attention.
Thank you, Dr. Chayathorn, for your conclusion of the step how to do a PMEG from. Do you have another idea to share or comment?
I have two questions. One about you talk about the anchorage and you use the getter or the cell curve to calculate how to you correct the accurate diameter in the anchorage neck or with the arch length. And the second question is about how many percent you reduce with the reducing time. We will if we over reducing it will difficult to calculate the fenestration, and if it is too small it will make a small room to calculate the native.
I think the angulated anatomy will affect the measurement of the length of visceral branch. Mostly I compare the center line length to the outer or lesser curve length and then adjust the position. Sometimes I use the 2 length plus and divide by 2 and we'll check again that when we plot is good or not. And if the length different too much, I will use the greater or lesser curve instead. And when we come from the arm, the outlet of the branch and the opening will be should be downward. So I tend to move fin higher if I think it different too much because it's easier to go down to the branch opening. And the second question is how to reduce how to calculate the diameter reducing time, right? We will reduce the diameter of the graft and make the space between the fabric and the aortic wall around 5 millimeter to 1 centimeter if we can. But if we meet the small lumen of the aorta, we just reduce only around 10% and have some gap between the graft and the aorta we can cannulate into the branch.
Instead of the double loop suture on the fenestration, sometimes we use the coil to do the marking suture. Do you recommend this method? And second question is that sometimes I found it's quite difficult to proper position the fenestration orifice when you reshape the graft into the original one. Have you provide any detailed information when you're going to reshape the stem graft? Yeah, sometimes you have some menu, means the technique to proper position the orifice. Yeah, when you're reshaping.
Thank you. The first question is about the coil. I do not have the experience to use the coil for reinforce around, but I think it's quite floppy. So during deployment, it's not gonna go back to its shape, but it's good to see in the fluoroscopy by the coil. I think. I think that's a good point, but I think if we use the coil, it's okay. But for me, I don't have the experience on it. And the second question is during we receive. I will show the picture. To prevent the misorientation, we will bring the fenestration out to anterior part first, and then we crimp around circumferentially by use the silk. This will prevent the misalignment of the graft. And during resheath, we have to align the stent graft, the dot on the delivery system up to 12 o'clock. Yes. So for me, for now, I use the silk, only silk tying like this. I use silk instead because it's quite easier to put back in the device and easier for the helper and also easy to adjust the fenestration position.
I think to just respond to two of your question, I think the first one, the reinforcement of the fenestration, I think it's not just to see under the flue. Actually, it's just to retain the fenestration shape and also to provide the perfect circumferential seal with the bridging stent. So you need some strong nitinol wire to make it retain. In the past, we use a wire. I used to use the lead, the lead wire of the pacemaker. It too bulky and too floppy. So when you compress and if you use the PMEG correctly, that means you place a fenestration in the healthy aorta that you have to oversize the graft, and then the fenestration will be oval shape or even compress smaller than that. So it will be difficult to cannulate later. And resheathing, I routinely use a crimper. So you don't have the problem with fenestration misalignment because it compresses the graft from every direction. So the graft will be compressed symmetrically. But the issue is that you have to make the suture around the fenestration quite smooth because of the exposed preload, exposed reinforced wire will catch up with the edge of the sheath. So sometimes you have to invaginate the fenestration and cover with the surrounding fabric to make it become the inside of the part of the graft and then use the resheathing technique.
Okay, let's I comment your question how to measure the angulated anatomy. In my practice, like aortic arch procedure, when I measure between the target vessel, I use the outer line, don't use the center line for PMEG arch. But for juxtarenal or thoracoabdominal with angulated anatomy, you can see the outer line and inner line. For the outer line, I use the length of the outer line. For example, with the infrarenal is angulated to the right. You can see the outer line to the right renal, and I can measure the length between SMA or celiac to the right renal and use the outer line, don't use the center line. But for the left renal, this is inner curve. For my experience, I use a mean between the center line and inner line. Most of the case is okay. Not misalignment or complete misalignment. But for angulated anatomy, the fenestration is not perfect because of it's really challenging.
If you use the center line, you have to deploy the graft according to that line. So it will be sometimes difficult. You have to deploy it. You have to push it up a little bit sometimes to make it perfectly conform to the anatomy. But Dr. Vidal mentioned is it's quite similar to the racing line. Basically, when we plan the graft, we use a racing line to expect the alignment of the rigid device inside the bodies and make it a little bit away from the wall, because anyway, when you deploy the graft will push itself away from the wall a little bit. So measure about radius of the diameter away from the inner curve will be one of the good proportion of the good position of the center line. And respond to your question about diameter reducing time. When we do the custom-made device, one set of the diameter reducing time is reduced diameter around 30%. And if you need extra room for cannulation for work or in challenging anatomy, let's say very angulated anatomy, it can be down to double set. It will be about 50% reduction of the diameter. But if it's too small, it will be difficult to cannulate. If it's too large, it will be fit with the wall and difficult to manipulate. So it will be in between.
And another technique for severe angulated anatomy is you should routinely use the diameter releasing tie and preload Y. And another technique, so if angulation more than 90 degree, you can use deploy the variant capillary under soft hydrophilic 2 and 2Y like infrarenal aorta. And after you complete deployment of the variant thoracic stent graft, sorry for variant capillary.
We have
I
one.
use only one product. Okay.
We
If
have
you
one
completely
question
deploy the
from Zoom
thoracic stent
meeting.
graft, the stent graft is will conform to the original anatomy, and the fenestration will nearly perfect, but never perfect for angulated anatomy. But it maybe it's easy. You can cannulate from the arm or from the groin, depending on the case by case. Okay, it's time to have a break.
One question from Dr. Gao in the Zoom. He asked that what maneuver do you do to prevent snacking of the preloaded Y? For me, I will do the tighten of the preloaded Y during resheath or insert it, so we can prevent the wrap around. Is there any other method for prevent this?
I use only the finger. My assistant, Dr. Big and Dr. Johnny will hold the stent graft around 70 or 30% of the reference visceral segment, and I suture with a 6-0 Polin, and some operator prefers 5-0 Polin.
So for now, it's time to have some coffee break. You can bring the coffee and some breaks, and we will go back here around 10:20.
He will talk about stepwise PMEG modification, fenestration, or branching, or preload Y, and how to resheathing. Dr. Watanakit, please.
Okay, thank you, Dr. Vira, for kind intervention, introduction. So my name is Watanaki. Hello. Okay, so my name is Watanakit Muthirangkoon from Washira Hospital. So first, thank you, Dr. Sheathorn, to invited me to sharing my experience in this wonderful conference. So about my topics, I will talk about how to do the fenestration or the branch or the preloading, and when should we do the fenestration or the branch. So I think everyone who perform the advanced complex aorta should know how about the concept about the fenestration or the branch. But today I will talk, and maybe for the beginner to know how to use it. For the first thing, I will talk just about the complex abdominal aortic aneurysm. As we all know, there is a juxta, short neck, the pararenal, paravisceral, and thoracal abdominal aortic aneurysm. Ow. Okay, so as we all know, for the guideline, like right now, the standardized of the endovascular treatment in the complex aorta is the fenestration and the branch. And what is the fenestration and what is the branch? The fenestration EVA, the term is the fenestrate endovascular repair, is applied when a stent graft with the fenestration is used to incorporate just in the visceral segment, and we can put the stent or the alignment of the orifice by using the bridging stent. So in the past, we can use the bare stent, but right now as the time right now we only use the cover stent because of the potency of the visceral and about the endoleak. And the branch is not the same. We have a lot of the name like a directional branch, the cuff, the portal, but the concept is we have the pre-soon side branch connected to the main graft, and we can use this to do to prevent the endoleak by use the bridging stent. And as you see from the slide, but the branch have a lot of the configuration. Like in the first one is the directional branch and the upward branch, and we have the inner branch, and for now today we have the bidirectional branch. We can use it for the directional branch is the simple, but for the upward branch, as we all know, maybe we can use in the upward position like on the renal artery, or when we use the inner branch in the angulated case or maybe the narrow case. And when we can predict that we should use the upper axis or the lower axis, we can use the bidirectional branch. This is the picture of the fenestration and the branch, and we can combine using the branch and the fenestration in some case. So I will talk a little more about the physician modified endograft because this is the PMEG workshop. So we can do both on the fenestration and the branch, but from my perspective, I usually do just only the inner branch because I try do the outer branch and it's harder to do the resheathing. We have to use more sheath size, so I think it's a little bit harder. So I right now I just perform the inner branch. So when we need to do the PMEG, I think that Dr. Vitawat tell us everything, so I will not talk about it. And about the planning, I will not talk it in depth because I think Dr. Shayathon talk it very good. But the concept is like when we do the advanced aorta, we have to dedicate the proximal landing zone, the distal landing zone, and the target vessel incorporation. And maybe we need to concern about the aortic coverage because about the spinal cord ischemia and about the access, what we need to access the visceral part, maybe from the upper or the lower. And maybe we can add about the additional technique like pilot Y, pilot cat, or maybe use the reducing tie. For the proximal landing zone, as we all know, we need to do the oversizing a little bit, maybe 10 to 15%, but we need the length around 25 with the good aortic segment, no angulation, no thrombus or calcification, or maybe the shape have to good. So we need to know about some technical term like a minimal recommended seal zone. So in this picture, we need the 20 millimeter. About the effective seal zone and the total use seal zone is just described from the fenestration as you see from the slide. For the effective seal zone, we not combine with the scallop or the large fen, but if we combine both, because the fenestration we can seal in the visceral part too, not in the branch. If you see on the branch, we can only have the seal zone just only on the proximal. So this is maybe you should know in the advanced aorta. And about the target vessel incorporation, what do we need to know about? First, we have to do the target vessel diameter, the direction of the target vessel, the location, and what should we do, fenestration or branch, and what should we use the bridging stent. For the diameter, if the diameter is too small, if the diameter is less than 4 millimeter, the higher risk of the operation is more. The rupture rate is increased and the patency is not good. Usually on the kidney, on the renal branch. And about the direction, I think is important too, because when we have to planning, like when we do the fenestration when we need to do the target vessel cannulation, if the downward band of the visceral maybe from the upper extremity is better, But if the upward direction from the lower, I mean from the limb is maybe cannulation is easier. And for planning of the branch, like I said before, maybe you should. I think everyone can picture a picture in when you see the picture. And another one is because this just talk about the branch, the renal artery tortuosity index. If the index is it's just about the patency. So if you can make it more good, the patency is really good. And about the arc length, I think Dr. Sheraton is talk a lot, but if you want to maybe talk it easier, we can call it like a clock position, like I show you on the slide, but I will not talk in depth because Dr. Sheraton talk a lot. So about the fenestration and branch, what should we concern, and how can we decided what, where, when, or how when the patient have to do. This is just for the PMEG. I do for it easier to know. First, I will consider about the aortic lumen. If the visceral part is normal or narrow, I usually use the fenestration, because I think everyone know that when the bridging stent is not longer, the patency is better. So for the FIWA, the concept is to make the fenestration just direct to the origin of the visceral part, so the bridging stent is shorter, so the patency is better. But if the aorta is larger, I mean like a thoracoabdominal aortic aneurysm, maybe fenestration is not good enough, because we can make the fenestration just beneath the origin of the visceral. So the branch is maybe the choice in the aortic lumen is larger. But the aortic coverage, when I show you on the proximal sealing zone, you will see that when you have to do the branch, maybe the proximal sealing zone is longer. So the risk of the spinal cord ischemia may be longer. But if we do the PMEG and we do the inner branch, we can minimize the coverage of the aorta. And the bridging stent, like I think everyone know, I tell you a lot, the fenestration may be shorter, so the patency is maybe better. About the access, if we do the custom-made device, the product usually want you to do the transfemoral access, because of if we do the upper extremity access, maybe the risk of the stroke is higher. So usually, but in the PMEG, if you just started, I think for the upper extremity access is easier. So I think maybe we can do both. But about the BIWA, if you do the directional branch, it's harder if you do the transfemoral access. So upper extremity access is maybe better. But if you have a sterile sheath, it's not the same. So, and another one, I think is important, if the stent graft is malalignment, or maybe you see the tortuous aorta, if you don't have any technique like Ajahn Vira, I think maybe we can do the branch is more acceptable for the malalignment. So that's my strategy to perform the fenestration and the BIWA. And about the bridging stent, I will talk a little bit. So when I think everyone know that when we use the branch, we need more. So we use the bigger pass. I think the result is better. You will see that we can prevent the stent graft fracture and prevent the patency. The patency is better because of the bigger pass. We have 2 layers of the cobalt chromium and 2 layers of the PTFE. It makes the graft more stronger, so we can prevent the stent fracture or improve the patency of the stent. And nowadays for the fenestration, I don't talk it before, but when we do the fenestration, we need to flare on the orifice to make it properly and avoid the endoleak. So the B flare right now is is the stent graft that have a balloon that taper, so we don't need to fly anymore. And for my experience, I think it's easier to swallow sheet back to the visceral part, and it reduces the time for the operator. This is a site, so you can ask the Nova Health or VideoThe team about this. And another one is the distal landing zone. So the distal landing zone, I think it's easier. We can just plan like a standard EVA because after we put the PMEG, we have a new neck. So, but for the oversizing or usually when we do the PMEG, if we use the graft like a 32 70x, I will use the bifurcate graft, size is 32. And about the another part, I think it's like a standard EVA. And aortic coverage, I talk a lot but in my experience, I fear a lot about the spinal cord ischemia. So I usually, if I can do the fenestration, I will aware that I will not seal the graft more than 5 centimeters or from the celiac artery because the spinal cord risk is higher. We have the procedure that we can prevent the spinal cord ischemia, like a state procedure, or maybe leave some branch, but I'm not comfort with the leaving of the some branch. So usually I do the state procedure. About the access, usually I think we can do just only the total femoral access when we do the PMEG, but if you just start the PMEG, I think maybe do the transfemoral is a lot, I mean a little bit challenging. So you can do the upper extremity access, just partially deploy the stent, and you can minimize a little bit of the graft, and I think it's more easier. And about the positioning, if the patient is, if you do the upper extremity access and patient is fat, I mean you can just avoid the arm, because when you have to positioning the flu and you have to put the arm here, it's a little bit hard to see the SMA. So if your anesthesia can and make you, I think this position is better. And another one is the arc classification. If you see the type 3 arc fenestration, maybe you can use the true and true Y or use the preload Y. It make the sheet more stability. And this is the additional technique that I want to share a little bit. The first one is the reducing time. The concept is to make the stent diameter less. I mean, if you deploy the stent and you plan it properly, the stent may be attached to the aortic wall. And when you add the reducing time, you can manipulate the stent easier and make the room for the cannulation. Another one is the preloaded Y. I think it helps you to access the branch or the fenestration, but nowadays I think I only use on the inner branch, because when we use the PTFE or the Dacron, when you have to select it, the inner branch, it harder to put the sheet inside. When you have the preloaded Y, it make you more stability. And I will share you about the step-by-step to create a PMEG. But I think the first is to deploy the stent graft. It had 2 techniques. The first one you have to capture first, but if you fully deploy, you can do it later. But if you have to partially deploy, I think when we tie the bare stent, it's more easier to recapture the stent graft. About the fenestration and the branch, I usually mark the fenestration first by the SMA at the 0 o'clock position, and then I will do everything by the do SMA as the marker. For the fenestration, I think Dr. Sheraton talked a lot. We can cut the fenestration by using only the scalpel or the cautery. And for the reinforce of the ring, you can use anything, but I usually use the double loop Y. And then About the suture material, I think just Polyene is enough, but if you want it to look better, maybe you can use CV or the Ethibond or the Glycon. But in my hospital, we very poor, so I use just only the Polyene. This is the look of the fenestration after we complete it. And about the branch, we can use many material. In my hospital, I only use the PTFE because about the reimbursement. But usually we can use the Dacron, or maybe if you rich enough in your country, you can use the cell expandable stent. But in my experience, I think after we do the branch, maybe you need to fix a little bit, because if you don't use the preloaded Y, when you have to cannulate it and you don't fix it, it's a lot harder. And maybe place the marker to locate the inlet of the branch. Or maybe if you have time enough, like Dr. Shiathorn, you can make the ring, another ring in the inlet. But I'm very lazy, so I just use the egg marker at the inlet of the inner branch. This is the picture that we complete the inner branch. You will see that the outlet is look like the fenestration, and we can put the PTFE inside, and the marker is just only the egg marker. We can cut on the upper of the stent graft. And this is looking inside. I think it's look very beautiful. So for the preloaded Y, Dr. Shiathorn talked a little bit. We have to puncture on the sheet of the stent graft, and then we can put on if you do the inner branch in the visceral part, you have to go outside in. But if you want to do the subclavian, you have to go the inside out. I think maybe Dr. Shiathorn will talk later. But for the concept, I think maybe you have to look closely, because you have to put the preload Y in between the strut. If you put in the strut, it not help anything. So be aware of it. And about the diameter reducing tie, right now we usually do the circular reducing tie because it's more easier and for the planning and for the operator to do. And I think it helps you to resheathing too, because after you reduce the diameter, the process that you have to do the resheath is very easy. This is I think it's called the Vira technique in Thailand. So I don't know everyone call but I call the Vira technique. And another reducing tie is the posterior reducing tie. You can do by the suturing around the strut here, and then put the 018Y to make it look like more reduced. But for my experience is a little bit time consuming. So right now I do it when I want. So but I think it's the same when we do. But the con of this technique is we can reduce more than 25%, because when we do the circular reducing tie, what you can reduce, I think maybe more than 50%. This is the technique, but for this technique, I put the Y in the last strut because we can manipulate a little bit when we do from the transfemoral. And for the resheathing, first I do just like snuggle. But nowadays, I think maybe just I try multiple technique. If you don't have anyone to help you, the suture of the stent is easier, but it's a lot of the time consuming. Or maybe you use the valve crimper. But if you use the valve crimper like this in the variant Medtronic device, it's maybe have some problem because you don't have distal fixation, so the graft may be enfolding a little bit. So when you have to do the resheathing, you have to do like a pressure on your left hand, and push a little bit from the right hand when we do the Medtronic. And when the graph, and when you see the graph is unfolding, you have to deploy a little bit. I think maybe in the workshop, maybe we can talk about that technique later. Another device that I used before is the Cook. The better is there is a distal fixation, so you don't need to put more pressure because the fixation is, you have the fixation, but the con is you have the minimal stent in the proximal. So I try to cut it, but it's impossible in my experience. So we need to use more sheets, and I don't use the Cook anymore for the PMEG. And this is the picture that we finalized the PMEG after we can do the resheathing. And about the distal fixation, I recommend to cut the bear off every case, because I have one case that I'm too lazy to cut and there is an endo leak. So nowadays I cut every case. And for the, if you want to preserve the hypogastric, you can do the fenestration for the iliac limb. For the conclusion, I think PMEG is one of the treatment option if we know a lot of the technique, and so we can just do in approach to achieve the successful in the case. So this is my presentation. Thank you.
Thank you, Dr. Watanakit. I don't agree with you. You are rich hospital, not a poor hospital. Because you use lots of atherectomy device.
Not me.
Any question from the participant?
So I would like to ask about the branch design. In your opinion, what is the length for the inner branch that you always do? And yes.
Okay. I have to see that what the case need the sealing. If the case needs if we do the branch in the large aorta, I usually put the branch just 15 millimeter. But if we just only do in the angulated case, and I think the sealing is enough in the visceral part, maybe we can do like a semi branch. So just a centimeter is enough in my opinion.
How do you think that? I mean, using the stent graft for bridging stent or only the PTFD, which one is better? I mean, it's like the sealing problem in the future. Is that stent graft much better? I mean, it's like in the future follow up.
You mean for the cuff, right?
The bridging stent, yeah, using the stent graft. Like in the branch, yeah.
Oh.
PTFE. Yeah.
Okay. So I usually for if I have to do the PMEG, I don't do the inner branch is the first choice. If I can do the off the shelf, I use the off the shelf. But in my center, I only use the PTFE, and I don't see any problem right now because the PTFE is a little bit cheaper. So, but I see some paper they use the cell expandable cover stent, and the outcome is better. But right now, my experience is only 2 years, so I can tell you that the PTFE is not good or better or anything. But 2-year experience is okay.
And another question is that sometimes we deal with a lot of the dissecting aneurysm with the small trumens. So how do you manage to treat this kind of patients with a very small compressed lumen when you try to do the PMEG?
Okay, so about the post dissection, I usually use the fenestration because but if you can close the entry, I think there is a remodeling to the lumen is maybe enlarged, but in some case that I experience, but I don't experience a lot, I do the fenestration in the small segment of the aorta, maybe 16. I think is the patency is 2 years. So
I can tell you more than 2 years, but 2 years I do the fenestration in this kind of case, and everything look okay right now.
So how about considering the remodeling of the future? I mean, like, because of the tumor already compressed, very small, but actually maybe we can do the septotomy to, I mean, the direct the two lumens to manage to insert the more larger stitches in the larger stent graft in the future for the remodeling of the aorta, instead of putting the small stent graft. I mean, it's like any prevention management to manage this kind of the true lumen, very small true lumen. Yeah.
Okay, so I'm not experienced a lot about this kind of case, but in the case that I manage, I will close the end, because usually in the post dissection is entry usually on the zone 3 or zone 2. So the first I will cover the entry first and follow maybe 1 month or 2 months and see that the remodeling is enlarged in the true lumen. If there is no remodeling, I think because of the chronic, usually it's chronic. So I think maybe the remodeling is not more than the after we close the entry. Yeah, but I think maybe Dr. Vitawat, Dr. Kiat, or Dr. Vila maybe can tell about this more than me, because I not have experience on this kind of case.
I would like to share some case that we treat the dissecting aneurysm with the fenestration. Mostly the case we choose the diameter from the maximum diameter of the true lumen. For example, mostly of the case of the true lumen present with like a crescent shape. So the long exit and short exit is very quite different. So mostly we choose the diameter of the PMEG stent from the maximum long exit, because of if there is the remodeling of the true lumen would be like a circle, so the diameter will be in the long exit. So that is my practice. And another thing is when the remodeling of the lumen is maybe cause the problem of the bridging stent, because of you cannot expect the how is remodeling. In some cases that we face, the problem is the remodeling is change the position of the bridging stent. So if we push the bridging stent too short, the 1C will occur, because of when it's remodeling, the bridging stent it changes the position. So it may be dislodgement of the bridging stent. So in case of this dissecting aneurysm, I would recommend to push a little bit more length of the bridging stent, maybe 1 centimeter in protrude into the maybe, but mostly the case right now we still treat with the fenestration.
Two of your points. I think the first one is to use we can name it Viaban for the cuff. I used it in the past, but the problem is that if you look at the Viaban itself, you can cut it, you can suture it, but it's quite very thin. The fabric of the Viaban is quite very thin, and I think we did one case many years ago, and about 5 years later, we faced a type 3 endoleaks from the cuff, from the suture line. So I think we use CV6 for that. Yes, and you don't have the metal part to hold the suture. It's hold only on the fabric of the Viaban. It's quite thin and it break down. Later, if after that external branch, so you have a leakage around the branch, and that's very difficult to fix. So I think the next case that I did the external branch with the Viaban, and we found the tear the torn part of the fabric. So we reinforce the outlet too. And we did, when we place the bridging stent, we fly it quite similar to the fenestration that prevent a little bit more type 3 endoleaks. And later when we move it into inside to the inner branch, so the function is quite similar to the fenestration. So that problem will not happen, but it's just bulky and costly to place a wire band to cut it, just very expensive. And regarding the post dissection, I think right now the trend moved back to the branch because of the, as Dr. Supong mentioned about the remodelings of the sacs. And also in the past we quite so afraid of the narrow aortic lumens, but later we found that by this kind of pathologies, we have more aortic remodeling later if you can seal the false element completely, and you have more breaching stent or target vessel issue. It's larger than we expected. We have 1C, we have some target vessel instability. So I think right now the trend even in European country, they move back to the branch, even external branch. Quite like similar to Dr. Supong. If you try to, in the past we try to put the fenestration. So we measure the longest axis that should be the original diameter of that aortic segment, the long diameter of the oval. But later when we move to the branch configuration, so anyway you have to taper the graft to put the branch, even external branch, so that will not be a problem. I think that will be more reasonable to use external branch than internal branch, because for the internal branch you have to decide the diameter of the aorta at the beginning, and when you place that in the narrow lumen you don't have a room for work for the branching bridging stent. You can dilate it later. You can do the kissing, you can do everything to dilate the true lumen up to dilate the aortic lumen, stent graft lumen, and later when it remodel, it should be adequate. So lately we plan the dissection branch with the I think in some countries you even the off the shelf. So you have some modification to just put the branch there. Probably be the way to go in the future with the branch.
Okay, thank you, Dr. Watanakit. You're from Rich Hospital, I confirm. And the next speaker is Dr. Cheyathorn. He will talk about bridging stent selection and operative step, access and deployment step. Dr. Cheyathorn, please.
Okay, thank you for the kind introduction. See you again in my second talk. This is the short talk about the operative step and bridging stent selection. I will follow this outline. As I mentioned before that the PMEG start before we enter the operating room, we'll prepare of the benchtop and back table modification leads us to have a successful during the operative session. But also the standardized operative step is not available yet. So for today, I will talk about my own technique that I do. Start with the operating room setup. I prefer to do in the hybrid operating room, but in some center that don't have the hybrid operating room, we can use the C-arm to do the PMEG. And we tend to use right upper extremity access, and all the surgeons stand on the right side and the C-arm come from the left side. As Dr. Watanakit mentioned a little bit about the arterial access, we use the bilateral common femoral access first by ultrasound guide puncture with 2 blow glide device for each groin. And for the upper extremity access, we tend to use the right side. We can use both of the puncture by 2 blow glide on the axillary artery or do the cut down to the right brachial artery as shown in this picture. The mother sheath will be 12 or 14 French sheaths, and the daughter sheath will be 6 to 8 French sheaths for target vessel cannulation. Then we step to the operating room, and first thing I During my early experience, I try to orientate the graft first in all of the case, so we can make sure that during we reload the device is good position without twisting, and mostly we place the SMA and egg marker at the same level like shown in this picture. First, we do the angiogram for SMA at 0 clock position and adjust the position of SMA fenestration at the opening of the SMA in AP diameter. And then we switch to the lateral view to make sure that the SMA opening and the fenestration at the same level. So this is one of the key steps to insert the device. You have to check the most important branch, which is SMA first, and then adjust the other branch to make it good position to cannulation. And then we go back to SMA at the 0 clock position again and starting to deploy. We mostly partially deploy until the celiac and SMA fenestration opening and start the selection. If you do the circular reducing tie or any kind of reducing tie, we can open the top cap and easier to get into the main graft. But if you don't do the reducing tie and meet the small lumen of the aorta, you have to do partially deploy combined with not to open the top cap and select into the strut. It's quite easier to manipulate the position of the fenestration. And then we start to select into the SMA first and exchange into the stiff guide wire. You can use the Supercore Ampass Rosen or any other guide wire that you're familiar with. If the stiff wire cannot place inside, you can shift into the double 018 guide wire instead. It's quite stiff and good support. And you can see that for this case, the left renal is quite difficult to cannulation with many adjunct technique required. So in this case, we put the 2018 guide wire, and I will put the long sheet inside the branch that I think is quite difficult to cannulation or to prevent it from this lock. And after we complete select into all visceral branch, include SMA and bilateral renal, the celiac is left opening, but most of the case I didn't deploy the bridging stent for the celiac artery. We exchange all of the visceral branch into the stiff wire and place the long sheet inside the branch that we think is quite difficult to cannulation, and then fully deploy the stent graft and capture the delivery system. After that, we will pop up our reducing time by use the aortic balloon. You will hear the click sound during you pop up by the aortic balloon. And then we start to deploy the bridging stent for each visceral vessel, branch by branch. The selection will start from above to below, but the bridging stent deployment will start from below to top. And in some case, we have to use adjunct technique like this, to use the balloon swallowing technique to insert the long sheath before deploy the bridging stent. So the key step for deploy the bridging stent is at one, the long sheath inside, position the adequate overlap from the fenestration or branch with the bridging stent and confirm the distal landing of target vessel. Then deploy the bridging stent. Most of the time we use the balloon expandable cover stent. If we do the fin, we have to flare inside the fenestration. And for each branch, we do the confirm angiography before proceed to the next branch. This is some kind of bridging stent selection that I will talk a bit about it. For the FIWA, mostly we use the balloon expandable cover stent, but for the BIWA, we can use either of the balloon expandable or self-expandable stent without that much difference. To compare between the cells and balloon expandable, for the fin, we can do the flaring after we deploy the balloon expandable bridging stent and have a good precise deployment but it's less flexibility than the self-expandable bridging stent. This is the review in the off-the-shelf device. They try to compare between the self-expandable and balloon expandable and found that for the branch design is not quite different between cells or balloon expandable covert stent. And as Dr. Watanakit mentioned before, the renal artery is one of the artery that can lose of its patency due to tortuosity. And this is the paper that compare the bridging stent graft between brand. I will not talk about the name of the brand, but you can see that some kind of bridging stent has a good patency around 95%, but this paper show that only 2 years because that kind of stent graft just recent adopt in that center. But you can see that in conclusion, they conclude that some kind of bridging stent graft cause loss of patency combined with deploy in the renal artery. Most of the time I train to use the B graft, and this is the in vivo design, result that they try to examine for the PTFE damage after flaring in the fenestration, and you can see that both of B graft and B graft plus is not quite different between flaring and not cause PTFE damage after deployment. And the B graft plus it show the higher pull out strength and also the shear stress. Like Dr. Watanakit already mentioned, we train to use the B graft plus for the branch design and B graft for the fenestration design. And you can use any other cell expandable stent for the tortuosity branch or to bridging between the branch and the inner branch. And this is our future that will be launched in Thailand and Asian country nearly. Some hospital experience to use this kind of stent. So for me, bridging stent selection is one of the key to have a good branch patency. But it's not only the one factor. It depends on the branch orientation. It depends on the branch tortuosity that Dr. Watanakit already mentioned it before. After we deploy all of the visceral branch, we proceed to do the EVAR step. In our early experience, we don't cut the proximal bare stent of the EVA, but for now we train to cut all of the proximal bare stent because it may cause some kind of type 3 endoleakage. And then for the EVA step, we deploy the bridging limb, and I learned from Dr. Vira that we train to use longer limb for curve into the tortuous anatomy. After we finish deployment of the EVA and all the bridging stent, we do the balloon to molding between the gap. And we perform the final angiogram. For the case that we do in the hybrid operating room, we can do the cone beam CT to check the alignment of the branch and also check for the bridging and the overlap of the stent. But if you do in the C-arm, you can do the single shot image to check all of the branch configuration and flaring of the bridging stent. And this is the next checklist that I try to list the essential equipment during the operation for just only simple PMEG that we train to use. The access site, we use the short sheet, and the bridging stent, we use the long sheets for the mother sheet, around 12 to 14 French, and 6 to 8 French sheet to the bridging stent deployment. And this is the equipment for the bridging stent cannulation and also catheter that we always use. This will help a lot to during first case, and you combine the checklist before the start the operation and the intraoperative planning. So my conclusion is that the meticulous planning before start the operation is the key to not have a problem during the pre-MEG operation, and think about the good workflow step by step will improve the efficiency and reproducibility in your center and also your team. And select the good bridging stent will lead us to get the good branch patency. And I also think that the standardized technique and checklist will help a lot during doing the PMEG procedure. Thank you.
Thank you, Dr. Chayathorn. Dr. Vitavan, do you have any comment? Do you have another step that not the same with Dr. Chayathorn? Please share your idea or experience.
I think most of the time I use the brachial cut down for right side, and I learned from you that you use the ultrasound guided puncture to axillary artery combined with two Poglis. Is there any extra step that you need to confirm during closure of the axillary artery?
My success of the percutaneous transaxillary approach is around 90%, not 100%. If you have to use this technique, you should have the cover stent for prevention of the 10% of the complication. For example, most of the complication is the pseudoaneurysm. And another one case I have experience with a double wall Pogli closure and occlusion because of I try in a small axillary artery, and I suggest you at least 7 mm for axillary. You can use the Pogli, but I cannot guarantee for the 100% success.
Have you encountered any patient will come back with the bridging stent occlusion, acute occlusion? So how do you manage to treat this kind of complication, and how do you to prevent the future occlusion after you manage to treat the problem? Yeah.
I met this kind of patient in the small native vessel like renal artery less than 5 millimeter. The bridging stent that we always the smallest bridging stent that we can use is only 5 mm. But if the native vessel is smaller than 5 mm or has some kind of pathology that's quite stenotic, I will try to pre-dilatation before we deploy the bridging stent, or pre-dilatation before start the PMEG. That this is my prevention strategy. But if the patient come back with a branch occlusion, I will examine that is it symptomatic. Like if one of the renal is occlusion and the other is still opening without any symptom, I will not do anything. But if the patient has symptomatic or maybe the major branch like SMA occlusion, I will do something. Maybe use the aspiration thrombectomy, or maybe use any other kind of procedure.
I mean, after you successfully treat the problem, and then how do you prevent any kind of further occlusion in the future? It means that the bridging stent might have something wrong. Yeah, maybe the tortuosity, maybe yeah. I mean, how do you manage prevent the future complication?
I'm still didn't meet the SMA occlusion with symptomatic yet, but I have one case with occlusion without symptom, and I just follow her. And for the case that I do the balloon dilatation after finish the thing, I just rely the new stent inside. But I'm not sure that any other kind of preventive strategy to treat this kind of patient. For me, I think if something may occur in the stent, I just rely the new one.
We dye a new stent
Yes.
inside it. Is it also the cover stent or the bare metal stent?
Cover stent.
Cover stent.
May I discuss? Is a very good question, because when you deploy the bridging stent, you should perform angiography in a different projection. The point of the concern is the kinking at the distal edge of the bridging stent, for example, renal artery. If I can see the kinking of the renal artery at the distal edge of the stent, I rely with a bare stent. Rely with bare cell expanding stent. Yeah, bare cell expanding.
Maybe can use the bare metal stent to reline
We can use the bare stent to rely or correct of the kinking.
Okay.
And another issue is that I have a dual antiplatelets. Dual antiplatelets, aspirin and clopidogrel.
Okay.
At least for my practice allow 6 months to 1 year. What about you?
Antiplatelet medication. Oh, okay.
I think for me it's a single antiplatelet, but the issue that you mentioned about the renals, I think is the fact that the renal branch can be compromised much more than SMA and slack trunk. I think longer branch with smaller target vessel, it should be a risk for renal occlusion, and we found some of them, and we have to fix later, because after checking the CT postoperatively, if we found some sharp angulation at the distal end of the graft, we try to come back to reline. But the option of the stent itself is quite, for me, I think it's important, because in the past, we rely a lot of this kind, because in the past we used 8 by 38 Advanta stent for the SMA. For the SMA, because we don't have any choice, the shorter one. And we found a lot of kink at the distal end of the SMA stent. We have to place a lot of bare metal stent. And lately, when you follow the patient, you can see the internal hyperplasia at the bare stent portion. So we have to rely again with the cell expanding cover stent. So later we prefer the shorter one. Don't want to rely, and later if we have to rely, I select the I can say the name. We use the pulsar because it's quite thin strut and a lot not less radial force to be additional injury to the vessel. So we try to do that strategy, and we come back to the original one. We use a short bridging stent that short enough but long enough to seal. I think that, and we have to pull back the guide wire and check angiogram in many projection before we leave that branch.
And another strategy, when you treat the Taiwan A endoly, and you can see in some case the strut of the previous aortic stent located at the origin of the renal artery, please make sure that the wires go into the last side of the, you can see the renal artery here and the strut here. The wires go to the larger side of the, you can use the pre-dilate or check with the balloon. If the balloon is a poor open, don't put the stent. That means maybe the stent occlusion. And I have the steps that are different from you. For example, if the SMA, you use the AP view for after you check the level of SMA. And for me, when the SMA is located at the 1 o'clock, 1 o'clock means 30 degree. 1 o'clock means I usually rotate the C-arm into the LAO 30 degree. 30 degree is 1 o'clock. And then we deploy the stent and we can rotate, and we focus on the SMA penetration in the center of the screen. That means the direction is perfect. Or if the SMA is 15 degree, I rotate to LAO. If SMA is 12:30, maybe rotate the C-arm to the LAO 15 degree. 15 degree. Right? It's okay.
I have some question about the stent occlusion. I experienced one case that I do the branch and the patient is accident with the car accident and the branch is occluded and I have to emergency to do the mechanical thrombectomy. So this is my question. What is the choice of the thrombectomy device that you use? I mean, I use in my experience, I only use the angiojet, but after we use the angiojet, I do the angiogram and there is a thrombus lining in the stent that I do the thrombectomy. So and in that case, I have to rely everything back and the outcome is okay, but I want some experience that what choice that do you use about the device of the mechanical thrombectomy?
In my experience, we use a pre-number. If we can assure that it's acute thrombus, because if you say that you do the angiojet and do some lysis and also mechanical, and you still see some thrombus lining, probably it's not thrombus lining, maybe intimal hyperplasia of the stent. So that relining should be the option to go. But for acute thrombosis, we use a pre-number or just a regular guiding sheet, guiding cat to do as and with the wax lock. Because it's quite deep and we need, it's quite fragile vessel, we need a very, very soft tip catheter to go inside. And later we use, eliminate the one with the thrombectomy catheters that use in the cardio and peripheral that can go with 7 French sheet and can have a long side with, you can keep the wire in. Because when you do the pre-number, the one thing that you have to remove the wire and difficult and also risky to manipulate the catheter in that fragile vessel, and we face some dissection and also the bleeding. So for me, sometimes quite similar to Dr. Chayathorn, that if the patient has no quite serious symptoms or didn't come in the early phase, we don't know exactly where it happened, so I leave it just there.
I would like to answer the question of the Dr. Wattanakit. It depends on the thrombus age. Some situation we can find the embolization during we do the operation. So the thrombus is very fresh. So the cord aspiration, for example, with the P number is quite good result. But in some situation, the patient come later after we do the operation, so you have to correlate with the history of the symptom and estimate the thrombus age. If the thrombus age is around 1 or 2 weeks, so the angiojet should be better because of you can adjunct with the RTPA from the pulse mode. So, but sometime when you use the angiojet, you will see some lining of the thrombus, and it's very difficult to remove it because of the tip of the device is depend on the position of the wire. So sometimes you have to rely the position of the wire, but in some time it cannot because of the thrombus age is very old. So in this situation we do like you, we will rely the new one stent to trap that's old one thrombus.
Another question about the penumbra. I never used it in the branch before, but I use a lot in the SFA part. When you will see that when we do the stenting in the SFA and you use the penumbra, when the pressure, the aspiration pressure, you can see that the stent is collapsed a little bit. So do you have any problem when you use in the branch that, in the small branch, right, renal artery. But I mean, I don't know. I just asked that when the pressure is high, there is any collapse of the stent.
I never experienced like this from the pre-number. It's okay in the small vessel.
I think it's quite close to the aorta, the flow, if you do the procedure correctly, so you shouldn't have problem with the flow. But I have some disagreement with Dr. Supong, because if we face the situation that we can assure that in more than a week, so I will not do the thrombectomy for that one, because if you know that it's later than 6 hours, it should not affect some renal recovery. So unless you have some incomplete occlusion or some presence of some collateral, and you still have a delay perfusion of the kidney, so in that case, I will do the correction of the occlusion of the branch. Otherwise, it shall leave it.
I agree with you because of the renal have the warm ischemic time. If you revascularize later, quite late, maybe get the risk more than benefit. But in that situation I mentioned with the SMA, when you see with the SMA, you should give the chance for the patient.
Hi, I have a question about stent thrombosis is one, but stent dislodgement. What are the tips and tricks to reduce the risk of stent dislodgement from the visceral artery? And if you have encountered stent dislodgement in your surveillance CT, how do you tackle that problem to realign the stent?
Actually, I have one case that have a stent dislodgement from the fin. For that case, I review my old procedure. I think I'm not good flaring enough, and also inadequate for the branch, the bridging stent protrude inside the aortic lumen. So I think the crucial step is to confirm the position during deployment, and most of the time we try to adjust the flow to the opening of the branch and protrude some part of the bridging stent inside the aortic lumen enough. It will prevent the stent graft dislodgement around 5 millimeter. But in that case, I select into the stent and rely a new bridging stent inside. Is there any tricks?
Okay, thank you very much, Dr. Chayathorn, for the share the good step of to do EVA. And next, we have another 3 challenging case. The first case presented by Dr. Wattanakit. No, Dr. Titinai from Washila Hospital.
Okay, thank you, Dr. Chayathorn, for having me here. So, let's begin with the first case with beginner level speaker. I am also new in this operation, so anyone can suggest me or comment. So our case was a Thai 78 years old with hypertension, DM, and coronary artery disease. At April this year, he accidentally found an abdominal aneurysm, and he underwent EVA with left PMEG IBD with coil embolization, like internal iliac artery. And at that time, we used the standard EVA and CTA follow-up after the operation. Seen 1A endoleak. So in this case, we plan to extend the proximal ceiling, and we discuss with the patient, and they prefer to do the PMEG. So first we plan. About the planning, the aortic diameter above the celiac artery is around 26 to 27, and diameter in the previous graph is around 27. But the previous EVA graph is 32. For the distance between visceral vessel is visceral segment is around 50 millimeter. So according to the aortic diameter above the celiac artery is around 26, 27. So we prefer to use the 30 millimeter diameter stent graft, and also the distal with 30. And what about the length of the graft? So we have 100 and 150 millimeter. The length below the renal artery to the fold divider of previous graft is around 30 to 40 millimeter. And the visceral segment is around 50 millimeter. So if you use 100, we can achieve the ceiling above the celiac artery around 20 to maybe 30 millimeter. And if we choose 150, it's around 70 millimeter. That's maybe too high for the patient. I mean the coverage length. So in this case, we select the 100 millimeter length stent graft. And for the clock position, we calculate, in my center, we used whole loss, but we can check the position with the company. And the celiac artery is around 31, SMA 20, and right renal artery 13, and left renal artery 73. And we always adjust the SMA to 0 degree and calculate the arch length using the stent graft diameter. And then the target vessel. So we measure the diameter of target vessel and also the gantry position. So you can see the position of the target vessel for cannulation. And also we estimate that where the graft end. I mean, so you can choose or prepare the range of the graft that you will use to put for bridging stent. And the gantry position should check the end of the bridging stent graft also. And the access. So in this case, the arch is okay. Now, minimal calcification, minimal thrombus, and not so tortuous. And also the femoral access, iliac access. So our instrument is 30 French, 30 millimeter diameter stent graft. It's come with 22 French sheet, and access is okay. So this is our plan. So we beginning with the graft modification. Okay. So in this case, this is the number which we calculate from our plan. And for the SMA, celiac, and right renal artery, we plan to do the fenestration. And what about the left renal artery? If you see the CTA at the beginning, there is some angulated angle of the left renal artery. So we discussed that in this case, will we use fenestration or branch? But after we discussed together we choose the inner band in this case because of the angulated angle of left renal artery. So we use the, after we deploy the graft, we use the blade number 11 to create the fenestration and reinforce with ensnare using proline 5O. And for the inner branch cuff, we use 6 millimeter PTFE and length about 10 millimeter. So after we reinforce the fenestration, we fix the inner cuff of inner branch, and at the second picture, we secure the proximal end of the inner branch cuff to the stent graft. And then we relocate the 8 marker from the top of the stent, move them to identify the SMA and the proximal part of inner branch cuff. Then we use 018 guide wire to do the preload guide wire. But be careful, as earlier speaker said, we should pass the preload wire through the red arrow, the smaller channel, because if you pass through the large one, the yellow arrow, when you open the top cap, the bare stud will trap your preload guide wire. Okay, after we finish our fenestration in the branch, so we use Dr. Vila technique or circular reducing tie. We use 5O proline and reduce a little bit, about 10 to 20%. Okay, and then we resheet the graft inside the sheet by the assistant use the 2O silk to encircle around the graft, and the surgeon reload it back into the sheet. Now our graft is ready, so we go to operation. And at this, in this patient, we always use upper extremity access and with a common femoral artery access. So we always orientate the graft before we insert into the patient first, and after we check the position, we insert the graft into the patient. The second video would like to show how we insert the graft, because we have one preload guide wire for the left renal inner branch, and so we snare the guide wire from the upper extremity access and pass the catheter through the common femoral access to externalize the catheter. And when we insert the instrument, we put the PMEG graft through the stiff wire and the inner branch to the catheter. Okay, so after the instrument is already inserted, we check the position, both AP view and perpendicular view to the SMA. In our center, we always deploy the instrument in perpendicular plane to SMA. Okay, and then open the top gap, partially deploy and cannulate branch by branch beginning at SMA and right renal artery. Okay. After we successfully cannulate the SMA and right renal artery, so in this case we secure the right renal artery first with the sheet and release the reducing tide before we cannulate the left renal artery. And then we put the bridging stent into SMA and right renal artery. And then we cannulate the left renal artery cuff and putting the bridging stent. The final angiogram is okay, not seen endoleak. Okay. So in my conclusion, keep learning, so do I. Keep learning, improving skill and teamwork is important. And experienced mentor, especially Dr. Vila, Dr. Vitwat and Dr. Kietisak. Also very important, so you can consult them before. If you not sure your plan, you can consult experienced doctor. And the most important is selected case. Not only selected which patient to do, but the patient can follow up. If they lost follow up, the outcome they may become with the thrombus of the branch or occlusion. Thank you.
Congratulations for your success. Do you have question?
Thank you for the presentation. I think I have the many questions in this case. For discussion, I think for discussion. Please feel free to the discussion. Sorry, this case I have question. Could you please explain a little bit why the patient had the type 1A endoleak after the first EVA? Because you put the 32 millimeter stent graft in the 26 to 27 aortic neck.
Yes, I think because the aortic at that part is not that not much calcified or thrombus, but it's angulated. So I think this is the most influent factor for this patient that this.
Is the neck angulated or not? At the first time in this, the neck is angulated or not?
Yes, it's angulated. It about 60 to 70 degrees. No, we did not put endo anchor in this case.
Just do the standard EVA with the IBD.
Yes.
And develop the type 1A endoleak. This time we collect the 1A by the PMEG.
Yes.
Okay. And I think it's not sure why the type 1A happened in this case, because of the preoperative is quite long, the neck, and not too much angle, and you put the more oversized.
Yes, and we experience some case with this situation. I mean, we already do the EVA within the IFU. I mean, we think we have enough coverage range and adequate sealing, but there are still 1A endoleak after follow-up.
Okay, I'm not sure. I don't know why. And the next question in this case, you do the PMEG on the tooth graft 30-30, right?
Yes.
And could you please explain a little bit why you choose the size, the 30?
Yes, we discussed, we have two ideas. We choose between the aortic diameter and the previous stent graft diameter. But in this case, the diameter at the previous stent graft is around 27 to 20, 26, 27, and we think that we can achieve adequate sealing between the previous stent and the new stent.
But the first one you choose the 32, right?
Yes.
But the new one, the tube graph, you use the 30. At the distal landing, you landing the 30 in the 32. What do you concern this point?
As as we see in this slide, we have the diameter around 2 centimeter that have diameter around 20, and 2 centimeter below is around 28.
Okay, can I answer the question? Because usually this is my case. So the first question is why there is a 1A endoleak. I think it's because of the type of the stent. I didn't use the, usually if in the angulated case, I will use the M product. But in this case, I use the A product. So I found it a lot of the problem in the standard neck. And this is, I think it is have a sealing zone a lot. I mean the 2 centimeter in the first time, and I do oversizing maybe around 18 to 20. So I think so I know I don't know about that. I think maybe the angulate that is the problem. And another question is why I use the 30, because in the visceral segment is not big enough, and in the part of the bare stent and the O neck, the diameter is around 20 to 22, as you see. So I don't fear that the stent may be not oversized enough, because I think the native is not that large. So the 30 is the choice, and the proximal is around 26 to 27. So in the PMEG case or advanced in my experience, I am not oversized much like in the angulated neck.
Sorry, in my experience, I mean that the angulation is not so too sharp for this case. And have you considered using the endo ankle to treat this 1A leak?
Yeah, I think endo anchor is another option, but in Thailand the endo anchor is not reimbursement, so patient have to pay everything for the endo anchor. But if I do the PMEG, everything is free. I think it's not a type 2. I think it's 1A, because the contrast is very fast, and it have a direction of the angiogram, and it see very fast, not in the AP. And due to the sac is around 10 centimeters, so I can't wait for the custom-made device, so I choose the PMEG.
May I ask the panelists too about the oversize or undersize to fix the type 1A endoleak? If we too much oversize, I think we fear about infolding. How much or about the we made the normal aorta in the proximal part too. How much should be concerned, or how much oversizing?
I think for me, probably we are. For me, in this case, probably the sizing diameter mismatch, just because we how to say, we fix our plan to the straight graph, so that you cannot modify the diameter correctly. So you have to compromise something proximally or distally. For me, I think if you have a type 1A endoleaks, and especially in this case, you have a little bit angulated ER at the beginning. Doesn't mean right now, if you measure the length of the trunk that you have remaining length right now is, I think, shorter than 5 centimeters. And if you place undersizing graft, so if you have some leaking, it will be difficult to fix. So for me, if you have how you say the mesh diameter, so you can use one straight graft, but if you have to make a consideration regarding the diameter, especially you need to a large diameter throughout the small visual artery, I probably go with, as mentioned earlier, to rely with the bifurcated graft. I think this will compromise me a lot to even to oversize at the visceral or less oversized at the ceiling. So we're not a problem to very difficult to fix later.
Okay, I have one question for you. Why you open the diameter reducing time before you cannulate into the left renal artery? Because if the alignment is not perfect, there is the chance of the very difficult. Sometimes it cannot cannulate into the target vessel. Why you open before cannulation?
It's very difficult to cannulate the right renal artery, and we think that we can already secure the right renal artery and the position of the left renal artery from the angiogram. It's not that difficult, so we change our plan in the case to release the reducing time first and cannulate the left renal artery later.
I do experience like this case, and sometimes we get not lucky. We after open the reducing tie, the stent graft it fully cover to the renal artery. It will maybe happen.
I think because you just want to put the sheet inside the right renal, right? Okay. One trick you can do, because you have one preloaded wire, you can follow with just the catheter to the branch. You do the body wire to secure the O1/8 wire inside the renal artery before you do that. It can be because in the past we use the preload wire in that way to follow that preload O1/8 with the catheters, and you have remaining movement to do the body. You place the catheter tip just at the orifice and you cannulate that one before, and you leave to guide wire before you choose the sheet inside the right renals, and you have a space for that too. And 12 French sheet, you have a room for 1/7 French and another one 035 that you can place many guide wire there.
Yeah.
Because in this case, when I do in the right renal artery, the sheet is not quite stable, and it's a little bit hard when I have to put the sheet inside. So due to I have the inner branch in the right renal artery, and I have the preloaded wire, so at that time I think maybe so I fear a lot about to cannot cannulate again in the right renal artery. I mean, for the put in the sheet, because of the strut of the old stent is a little bit interfere. So at that time, I think that if I can save just only one renal is okay. So I want to keep it both, and I think is 50-50, so I have to put the stent in the right renal artery, and then I have to release the reducing tie, and then again. So I think because I have the preloaded wire, so I not fear that after I have to release the diameter, I think it may have the possibility because of the releasing, I mean the preloaded wire. So that's my strategy in that at that time.
Okay, congratulations for your success.
Thank you.
And the next case from Prince of Songkhla University, Dr. Supong will show us about the interesting case.
Good morning, everyone. I'm Supong Waratan Manon from PSU Pin of Songkhla University. Thank the Chiang Mai team and Belly for invitation to share our cases that we treat with the PMEG. So the case that I choose today, we use the PMEG in the urgent situation. So I have no disclosure. I'm from the Prince of Songkhla University, the southern part of the Thailand. So let's move to our case. Normally we use the PMEG in the complex anatomy. For example, the thoracoabdominal aortic aneurysm. And also some case that we deal with the infrarenal aorta, but the neck is healthy. We call the challenging infrarenal neck, for example, the hostile neck. So this case is the 79-year-old. He had the AAA and also repair with the open repair 13 years ago from the other hospital. But this time he present with the abdominal pain. So at that time, the pain around the aneurysm, we can palpate the aneurysm around the mid abdomen. So at that time we think about the symptomatic AAA. So we perform the CTA, and you can see the previous aortic graft at the abdomen, and you can see the heel of the sacral aneurysm around the anastomosis of the previous graft. So in this case, the patient have the para-anastomotic aneurysm. So the locate around the juxta-renal area. At that time, we need the healthy sealing, so we have to get the sealing at the suprarenal artery. So in that time, we think about the PMEG. Because of the patient come with the urgent situation. So this anatomy, you can see the para-anastomotic aneurysm around 7 centimeters, and the previous aortic graft very kinking, and the SMA and left renal is very close, almost the same level. And the patient has the single kidney. You can see the light kidney is gone already. So this the sketch and sizing. The aorta around supraceliac artery around 26, and the visceral segment 25, and the previous aortic stent. We can get the information of the operative detail, but from the CT we can measure the aortic graft. The previous one is around 22. So the access is not is quite good, it's not problem. So in this case, we did this the clock or the vessel cooperation. You can see the celiac opening around the 10 degree. The SMA and left renal artery almost the same level. The SMA around 12 o'clock, and the left renal around the 115 degree. The distance between celiac to the SMA around 10 millimeter, 1 centimeter. So in this case, we plan to use the graft variant captiva 30, 26, 150 in long. So the configuration in this case, we think about the fenestration for the celiac artery. And we do the inner branch for the SMA and the left renal artery because it's almost the same level, and the opening of the SMA and the left renal artery in the level of the aneurysm. So you can see when we, I think we will talk in the detail of the measurement again in the workshop, but normally the taper gap is not 30 to 20, but it's taper around every 5 centimeters. So you have to measure the area that you make the hole of fenestation, what is the diameter. So in this case, we plan to make the fenestation and the inner band around 5 centimeters above the below. So that area is around 28 mm. So you have to measure the cock position and the arc length from the 28 mm. In this case, the problem when the consideration issue when we do the PMEG in the previous aortic stent, you will face with the mark resistance. You can move the PMEG stent a lot, so you have to precise deployment. So in this case, we do the inner branch configuration, so we plan to put the payload. But in this case, we don't do the diameter reducing because of only one fenestation that we have to focus is the celiac artery, and we cannot move the PMEG stent too much in the previous aortic stent. So we have to just partially deploy until the inner branch can cannulation, and we put the bridging stent. So we cannot do the diameter reducing. Why? Because of if we have to do the circumferential diameter reducing, why we have to deploy all of the stent and pop up with the aortic balloon. So in this case, we think that we have to only focus at the SMA, and we have to push the bridging stent in the partially deploy of the PMEG stent. So the diameter reducing is not needed in this case. So let's move to our operation. First, on the table deployment, we have to push the payload right, so we have to totally deployment of the graph for measurement the fenestation hole. So for our familiar to make the fenestation hole, we do the electrocautery pen. And we reinforcement with the double snare wire. You can see the benefit of the PMEG is we can adjust or adaptation of the direction of the band. You can see the SMA and the celiac artery is very close, only just 1 centimeter. So, and almost the same arc branch, 0 degree and 10 degree. So the fenestation and the inlet is almost the same arc length. So the direction of the inner band you can adjust a bit by rotate the direction the inner branch like this. So this is the benefit for the PMEG stent. You can adjust or adapt depend on the situation. So the inner branch we use the Dacron gap. So, as the previous speaker mentioned, you can use the PTFE or the Dacron is almost the same, but the PTFE is that's we have they have only we don't have the thin PTFE, so it's very difficult to make the 2 PTFE of the inner branch in the same level. It's difficult to recapture of the stent, but different from the Dacron gap, you can push the 2 Dacron inner branch in the same level. It's easier to recap the stent into the race system. So Finally, after we complete make the fenestration hole and inner branch, we push the radio-opaque marker to locate where is the inlet of the inner branch by use the pigtail marker. And we change the location of the edge marker to define the location of the proximal edge of the SMA fenestration. And make the payload wide and recapture stent. In the same fashion, we use the only snuggle and seal to wrap the stent and recapture into the delivery system. So this time the PMEG is ready for use to move to in our operating theater. For the access, we start with the totally percutaneous approach by the puncture the proximal brachial artery and bilateral common femoral artery. That I mentioned before, when you puncture of the proximal brachial artery or the distal axillary artery, you have to define the medial nerve by the ultrasound. Sometimes we can puncture through the medial nerve into the brachial artery, so it make the complication post-op. So from the brachial access, we push the mother sheath 12 fan sheaths 45 centimeter in long to protect the art, and push the daughter sheath 7 fan sheath to do the vessel cannulation and stenting. In this case, we make it through and through. Why? Because of firstly, we think the kinking position of the previous scarf may make the problem when we push the delivery system of the PMEG. But in the operating room, it's not make the problem too much. So first, we start with the posterior aortogram. So when we make the fenestration, we focus on the SMA. So the SMA should be on the 0 degree. So I would recommend to adjust the C-arm to see the SMA in the truly AP position. So, but in this case, the SMA is open at the 0 degree. So no need to adjust in this case. But usually we should adjust to the 0 position of the SMA. So check the PMEG stent again where is the radio-opaque marker, because sometimes when you recapture the PMEG stent, the location may be changed a bit, so you have to check it again. So bring the PMEG stent up and deploy. In this case, we partially deploy until the celiac artery opening. And then we cannulate the celiac artery first because of only one target vessel that we have to focus is the celiac artery. So we leave the supercore. Then we continue deploy until the SMA and renal artery opening. And we use the true and true Y to push the daughter sheath into the inlet of the target vessel. As I talked before, in this case, we plan to stenting the left renal artery first because of, you can see the scapula is protrude into the left renal artery. So it's very difficult to manipulate the sheath into the left renal artery. And sometimes if you manipulate too much when you completely deploy in the small lumen or in some area of the fixed marked resistance. For example, deploy the PMEG in the previous aortic stent or previous stent, it make the PMEG stent jump a little bit. So may make the malalignment of the fenestration or the inner branch. So in this case, we just partially deploy, complete cannulation and stent first, So in this case, we push the left renal stent, and completely after complete the deploy the left renal stent, we complete deploy totally PMEG stent and do the SMA and select stenting. So we have to sure that the overlapping area has complete apposition. So we should recommend to do the balloon molding. And this is the final aortogram. You can see the position of the stent is quite good. No endo leak. So the process of the patient is able to discharge 3 days after operation without the uneventful event. The follow-up right now is one year and 3 months. No endo leak, good stent position, and renal function is stable, 1.6. So for the conclusion, the PMEG in the urgent situation is still the backup tool for treat the patient, especially in the complex anatomy. So, but the judicious planning is very important to do the operation like a PMEG. And finally, let's say that the final angiogram is not enough to prove our success, but the long-term follow-up is very necessary. And finally, the key of success is the team. So for the complex aortic intervention, we need the team. Thank you for your attention.
Thank you very much for challenging case. I have one question for you. What kind of the stent that you put into the left renal artery? You put the balloon cover stent or self-expanding stent? Because I see the angulation at 90 degree.
Yeah, we push the 2 balloon expandable stent, bigger plus 2 pieces. But some a little bit challenging because of the previous one. The first one that we push is the distal, and the proximal of the distal stent is not in the inner cuff, so it's very difficult to intubate the sheath again for the second stent. It take time a bit, but it can.
Yeah. That's a problem.
Yeah.
For this case, if maybe wire band or coppola, maybe another good choice.
Yeah, another choice is the longest one of the cover stent is the wire band, the self-expandable cover stent. There is the longest 110 centimeter, but at that time is not available.
Okay.
So we have no choice.
From the CTA, look at the renal artery bridging stent. Do you see the collapse or kinking at the angulation or compromise the lumen of the angulation of the left renal artery? I concerned about this because I have a best experience with the chimney technique, and the chimney stent is a 90 degree angulation, and after that the problem is a chimney stent occlusion.
In this case, I think is the angle is quite not severe angulation after we put the stent. From the preoperative CT, maybe sometime you can see the angle of the target vessel, but it change a bit after you push the bridging stent. So you can change the shape a bit.
And after
like
after you deploy the 2B graft into for renal bridging stent, do you use another new balloon, long balloon to inflate for good sealing between the 2 bridging stent?
No, just use the previous one. Yep.
Let me ask you some question about the planning perspective. Comparing with have one fenestration for the SMA and bridging the branch for the celiac artery. Compare with this one, the fen for the celiac artery and the branch for the SMA. What is your
This
preference
this
to pilot?
this choice is also in one choice that we think about, but at that time we think the SMA and renal quite the same position, and you can see the sacral aneurysm is nearly close to the SMA ostium, so the fenestration may cause of the endoleak from the fenestration configuration. So I think the branch for the SMA is better in for our opinion.
But I agree, but actually I agree this one because the same idea is that probably if we have the leakage from the SMA branch, SMA stent, fenestration, there will be cause some leaking to the aneurysm.
Yeah.
They'll be more secure, but you have to face with the double branch in the same level instead.
Okay, because of we have some delay from the schedule. Thank you, Dr. Supong, for your good case.
So the third case discussion will move to the afternoon session. Before we go for lunch, I'd like to have some special gift for our speaker. Please, may I invite Associate Dean of Faculty of Medicine, Dr. Saranat Orapin. He is also our vascular member. He will give a special gift for our speaker. Please, Dr. Virat. And Dr. Kietisak, or Dr. Vitawat first. And Dr. Kietisak. Dr. Kitty. Dr. Supong. And followed by Dr. Virapat and Dr. Titinai. Our last speaker will be receive the gift later, and after this, I would like Dr. Titinai. After this, I would like to invite all of the members to take a group photo before we have some lunch. ตรงไหนข้างหน้าข้างหน้าตรงนี้
ขาเป็นไรพี่
ตรงนี้ครับเอาสปีกเกอร์อย่างเดียวนะ
ไม่งั้นเราไปนั่งไหมแล้วให้กดตะกล้องมาถ่ายตรงนี้
นั่งก็ได้นะแล้วแต่กล้องถ่ายเข้าไปก็
เอาสปีกเกอร์ก่อนก็ได้ครับเอาไปข้างนอกเหรอ Oh, okay, so we will take a picture outside. Please follow me. For the online session, thank you for joining us today. And during the afternoon, we will not spread out the Zoom conference. For the Zoom is finished already. Thank you for joining us today, and hopefully, if we have some conference or workshop, I will tell you again later. Thank you very much.
Our colleagues from Mahalan Nakhon Ratchasima Hospital, will present about aortic arch PMEG. Please.
Okay, so good afternoon, everyone. After we finish the lunch, so before we go to the workshop, there's two cases of our arch case, aortic arch case. Yeah. So I'm the Dr. Vilapa from Korat Hospital. Okay, so case one is a 60 years old man with dissecting thoracic aneurysm. And here's CT angiography. You can see there are huge aneurysm here and also the false lumen and very narrow true lumen down to about the celiac level. And for the below, it look quite okay. Okay, so there's a large thoracic aneurysm, about 9.9, and you look at the ceiling zone, you can see that we have to put the stent in the zone 1 for the proximal ceiling. Yeah, maybe 20 or 25 millimeters for the next ceiling zone. So for device selection, the proximal landing zone at the zone 1 may be 38, and for the distal landing zone is about 34. So the neck length that we choose is about 20 millimeters, so that we plan to put the stent in the zone 1. So we're going to do the zone 1 TVAR. And for device selection, depend on the diameters of the aorta. So we choose the VAMF 4238, the taper one, it was 150. And for the distal, we plan to do the stage after maybe 4 weeks to do the stage TVAR after that for not cover too much landing zone in this case. Yeah. And for the fenestration, in this case, the left common carotid artery is about 10 or 9 at the side of ceiling zone. So we plan to use the B graph 9, and posterior is maybe about 10 or 12. And we plan to go from the femoral SS, and here's the claw position. And for left subclavian artery, the size may be around 12. So we introduced the B guard 12 and posterior with the balloon 14, and we plan to come from the femoral SS also. Okay, so in our hospital, we don't have any of the child device or branch heart device, so we have to do the PMEG in this case. So the fenestration creation, we measure the two parameters. The first one is the distance, and the second one, in our practice, we use the claw position. We don't measure the arc length. Yeah, so the claw position, the original claw position of the left common carotid artery is at 1330, and for the left subclavian artery it's 1345. So we can just adjust to the 12 o'clock for more easier to measure the fenestration. And the size was depend on the target vessel, so it's 10 and 12 for the left subclavian artery. And the distance that we use in the arch device, we have to measure the outer curve. So we use the distal border of the intermediate artery as a reference point to the left common carotid artery is maybe 5 millimeters. And for the distal border of intermediate artery to the left subclavian artery is about 22. So depending, we have like this, it's not 30, it's 42, 38, yeah. So the reference point is 5 millimeters from the proximal stent to the left common carotid artery, and make a hole about 10. And for left subclavian artery is about 22 from the distal border of intermediate artery, the reference price, and the hole is about maybe 12. And for the endograft modification, so there's many to talk about this morning. So the first, we have to tie up the proximal bar to prevent the stent bob up, because it's quite difficult to recapture it. So it will look like this one. We use the SU10 to tie up the proximal bar stent, and we use the scalpel to make a hole. Yeah, to make a hole. Yes, more. And for reinforcement of the fenestration, we use the double snare ring. Yeah, actually we have used many times of wire before, but this is come from more conformable, and when we squeeze, recapture the stent, you can open up just like the normal ring, a round one. And the suture that we use, the Dicon 5.0 for suture the reinforce the snare. Yeah. So the stent web like this one, you can see the distal border of iliac artery, 5 millimeters to the left common carotid artery, and 22 to the left subclavian artery. And in the arch case, we always put the preload wire in to with this 18G needle, you can just direct puncture into the sheet and put the wire in. And for the more distal one, you use the 035 for more strength to when we bring the graft up. And we also, it will be like this one. So we just direct puncture into the sheet and put the wire in. You can flash some satellite for more easier because maybe some fraction when you put the wire in. And for now, we always put, if we have two fenestration, we always put the second pillow wire in also. So in this case, we put two pillow wire. So one is 035 for the distal one, and another one is the subclavian. We use the 18 wire. Okay, and the problem with the arch is that it's quite difficult to rotate the fenestration open perpendicularly to the target vessel, especially in the like type 3 aortic arch. So in our practice, we always put the reducing wire. In the aortic arch, we put the posterior reducing wire. We use the Polin 50 suture, and the length is depend on the fenestration. So if there's two fans, so the posterior reducing height may cover the two fenestration. So it will be like this one, and here's and we use the V18 as a reducing wire because it's more stiff than the common ST, like something like that. So after we open the reducing, they will be work like this one. Okay, so the reducing segment is depend on the fenestration, and the size of reducing is depend on the inner diameter of aortic arch. So you can see the middle one, you can see there's the preload wire, two preload wire, the 035 and the 018, and they're also the reducing wire V18 in for the posterior reducing wire. Okay, so for retreating or someone called reloading, we in our practice we only use the simple seal and coordination with the assistants. And before we completely reloading the sheet, you have to ensure that the preload wire must be in the same alignment of the preload, same alignment of the distal fenestration. In this case, is left common carotid artery. And don't forget to cut off the seal. And for now, for more easier to manipulate the stent, we always before we cut we have to snare 3 wire if we have 3 wire, the reducing wire and the preload wire and the preload wire. But for now, we cut the reducing wire and just put back to the sheet for more easier to manipulation. So you have to just handle for only 2 wire. So it's not too yep. And crucial pillow wire with the penrose. Yeah. So the final, after we modify the stent graft, it will look like this one. You can see the reducing wire in the after we cut the end, the distal end, we can just put back to into the delivery system. And there's 035 and 01A pillow wire here. And for the exercise in our practice, if you know any contraindication like small axillary artery or plaque of common carotid artery, we always do to the total percutaneous approach for the OSS. So for a femoral is okay and the common is okay. And so the below we just put one side for the main body, and another side we also put a sheet in the common femoral artery for control the BP when we deploy the stent for the IVC occlusion, because it's more, in our practice I think that it's more smoother than when we let the anesthesiology do the job. Yeah. And another small sheet just for the angiography. And for the axillary artery, the inner diameter is okay. And this is another point. Another problem is arch TVAR is that there are many quite high of stroke rate, maybe 10, 15, or maybe approximately 20. So in our practice, if there's zone 1, so we always put the filter in. Like zone 1, we put filter in the left internal carotid artery and the left vertical artery. But if there's zone 0, we put 4 filter in. So in this case, for the internal carotid artery, just direct puncture in the antegrade fashion and put just a small sheet, the 4-fan sheet, and we can just directly put the filter in from the neck. And for the vertebral artery, we always come from the brachial artery. Cool. So it's like a little bit step like this one. You can see there's a 4-inch anti-grade fashion, and this one is for the internal carotid artery filter. And there's a left brachial artery that is for the left vertebral artery filter. And you can see there's a retrograde sheet, 6-French sheet for the retrograde left common carotid puncture that we have to use to capture the preload wire. So after that, we will kosher with just a vascular kosher device. Okay, so here's the step for protection. We cannulate into the left vertebral artery. Sometimes we use the 4 French catheters. Sometimes we just use only wire and the delivery system of the Spider FX. And in this case, you can see there are a little bit tortuous of the proximal vertebral artery. So we have to use the double V18 and put the wire in. Yeah. So if you use the 4-French, you can just directly put the Spider FX in the vertebral artery. And for the internal carotid artery, just direct puncture into the common carotid artery and just put the filter in. Okay, so another key point is that during the operation, the filter can cause some problem like slow flow if there's too much debris or you have the low ACT level. So we always do the internal angiography, maybe 30 minutes, 40 minutes for check, because sometimes you can see the problem is the slow flow if you too much manipulation of the aortic arch and it cause some plaque debris into the spider. So we have to put out and wash it and put back in. So after remove the filter, the flow is getting better. Okay, so in this case, we snap the 2 and 2Y from the left common carotid artery down to the femoral SS, and we use a long sheet, maybe 7 French sheet 90, and to capture the 2 pillow wire. And between the way, we confirm the true lumen passage. And during deployment, we'll inflate the IVC balloon to control the SPP around 80 or 90. During the deployment of main body. And the step deployment will be like this. First, we have to do the orientation because the issue is that some of preload wire will be stuck with the stiff wire. And then we do the deployment. And during the deployment, we use the balloon fixation and we have the reducing wire. So you can see the graft is the endograft will be rotate that the actual side they will be in. And then we remove the reducing wire and we fully deploy. So it will be like this one. So first we advance the endograft and we rotate the orientation to ensure that there's no stuck between the preload wire and the stiff wire. And during the bring up, we have to, the assistant have to coordination to knock the wire wrap around the stand. So you can see the wires in the outer curve. And you can see there's a balloon. The balloon just the size of the balloon is same as the fenestration. So in this case, we used a 10 by 40 balloon. And after deployment, we inflate the balloon and yeah, so we inflate the balloon. You can see the graft rotate a little bit. In this case, yeah. And then we remove the reducing wire. So you can see the graft expansion. And then we deflate the balloon and free deploy. Okay, so here's how we to make sure that and ensure that there is no any wrapping between the preload wire and the stiff wire. So we use the menu view to identify it, and the preload wire must be in the outer curve. So there are some example for the example because this case you can see very clear about the balloon fixation and you remove the reducing wire. So you can see after we inflate the balloon, the stand will be turned in the right position and then we remove the reducing wire and fully deploy. But sometimes it can also cause the problem. You can see the fenestration of left subclavian artery. In this case, I push too much a little bit so you can see the fenestration jump up a little bit. So, but we are lucky that we have the preload wire in the subclavian artery. Okay, yep. So you can see the fenestration of left subclavian jump forward a little bit. But we're lucky that we have the preload wire. So we use the snare and we puncture the left subclavian artery. So we can successful cannulation into because they have some space, so we can cannulate into the stent, and we use the long sheet and put the snare for snare the wire from the left subclavian artery. Okay, and then we put the bridging stent in. So everything will come from below the femoral. So we don't have to put a large sheet in the aortic artery or left subclavian artery. So for the left common aortic artery, we put the B gap 9/37 and we post dilate it. And we always cannulate into the ascending aortic arch for the good confirmation, the configuration of the bridging stent. And for the left subclavian artery, also come from the below, and do the angiogram to ensure that there is not coverage of the vertebral artery. And post-dilate with the balloon 14. Okay, so you can see the distance between the common artery is better than before that we just deployed the stent. Okay, so the final angio show the okay result. It's not okay, yeah. And then we remove the filter in the internal aortic first, and we do the angiogram to ensure that there's no any filling defect. And we also, and then this one for the vertebral artery. So there's no any filling defect or slow flow. And actually maybe more than 95% of case in zone 1 or zone 0 that we put the filter, we always found there's some debris, always found some debris, but not in the zone 2. So for now, our routinely practice, we put the filter in the zone 1 and zone 0. So after we put a stent, you can see even the gap jump forward a little bit, but after we put a bridging stent, this seems okay. Yeah, and we do the second stage TWAR after that about 4 weeks. And the patient can be discharged safely, and the patient may become follow-up in the next 2 months. Okay, yeah. Okay, and for the second case, more easier. It's a zone 2 case, very short. 40 years old man, ESRD on hemodialysis, and with the sharp shooting pain, and CT showed the type B LD dissection, and the pain is not improved after we do the full medication, and also there's a very large entry tear, about 2 centimeters. So, and you can see the entry tear is just beneath the left subclavian artery. So in this case, we plan to do the zone 2 TVAR. So for device selection, the proximal is 38 and distal 34. So we put the 42, 38, 150 VAMF, and just do the one fenestration. The size it depends on the left subclavian artery. Yeah, we plan to use the BGAF Aortic 12/49 and post-dilate with balloon 14. And so the creation is just like the same. So I will skip this. Okay, so and in zone 2 we use only one preload wire, and you don't need to put the filter, you don't need to do the reducing wire, anything like that. So it's more easier. And the SSI is okay, you just can put the only sheeting. And for the left subclavian artery, the size is okay for kosher. Yeah. So first we confirm the true lumen passage. During we bring up the steep wire. And then we arrange the endograft, and just is quite similar like the before. Just we have to check about the wrapping between the preload wire and steep wire, and then we bring up a stent and deploy it. Okay, so you can see the sheath in the outer curve and do the angiogram, and we use the IVC balloon to control the BP during the deployment. Yeah. Okay, and actually for the zone 2 now, we can just do under the nerve block with no sedation. If the patient cooperates, you have to do the GA, you don't have to put too much thing in, so it's more easier. And after refixation, we fully deploy and we put stent in. Okay, so here's the final. The final seems okay, yep. And for the percutaneous closure, if the sheath is not larger than the 9 French, we can just use only one procli. But if there's, you would have to use a large sheet, maybe 10, 12, or 14. We always put the pre-closed guy for two pre-closed guy in. Yeah. Okay, thank you. So there are 2 cases. Yeah.
Thank you, Dr. Johnny, for the interesting case. I had some question. The first one, if we don't have the embryonic protection device, how do you suggest what can we do? The first one, and if we do the protective device and we still decrease blood pressure by the balloon inflation in the IVC, it maybe get more risk for the stroke or not?
Yeah, so first one, we have to ensure that the ACT is more than 300. In case like this, the TVAR is not only 250, so it's 300. And actually, during the deployment, the IVC balloon occlusion is just a very short period of time. So for now, actually, I have not any long-term data, but for now, we don't face any problem about the clot or slow flow after we deploy the stent under the IVC balloon occlusion. Yeah, but we have some experience, like very difficult to cannulate into the vertebral artery is zone 0 TVAR. And the bad things happen in the just only branch that we did not put the filter in. Maybe 2 cases in that we don't put the filter in. So after that, we will try to cannulate as possible, but not too aggressive, because sometimes the cannulation may cause dissection and make the thing go bad. So for now, we have tried our best to put the filter in for now, yeah.
Thank you, Dr. Johnny, for great presentation. I would like to ask you for the first case, may I miss some step? You push the true and true Y, OT5 and O18, but you just do the true and true catheter for only the OT5, and how about the O1H? You just leave it.
Okay. So actually, first we start with true and true wire. So that will be a true and true wire with O35 from the left common celtic to the femoral. And after that, we use maybe 7 French sheet, 90 lengths, 90 for capture. So if in the 7 French sheets or even 6 French sheets, you can put one O35 and one O18 in the same sheet. Okay. So that may be possible to capture 2Y in the same step. Yeah.
But both of them is only in the same way from common femoral artery to the left carotid artery, right?
Yes,
okay.
at the first. But after we do the fully deployment in the cannulation step, maybe we can, because if you have a preload wide leg in the subclavian artery, if we put the long sheet in, the long sheet will very close to the left subclavian fenestration. So even we can cannulate from the femoral, it may be possible. Maybe we don't have to use the preload wide, but in some case, like this case, I push a little bit too much, so the preload wide can be help us. Yeah.
So the second question is, what do you think about almost the case that we face the innominate and left carotid is very almost the case very close. So how different approach for case like this? What case you choose to do the zone 0 and or what case you just do the only zone 1 like this? Because you can see almost the case that we just repair on the zone 1. Can you show the final angiogram?
Final
The tip of the basin, almost the case is direction is direct to the innominate ostium. Do you have any experience of this problem about the basin in the innominate ostium, right?
Okay, so actually it's depend on the best planning at first. And the stent that we protrude into the lumen is just only maybe 1 centimeter, as you mentioned before. And actually almost the case, if the direction is okay, the stent that protrude in the lumen will not be covered or interrupt the flow of innominate artery. And actually the innominate artery is quite large. So actually it's very difficult to see the stent in the left common cavity artery and the cause problem to the flow of innominate artery. Yeah.
Do you have any problem after do the reintervention in some case like this?
Yeah, actually in the first experience, we just put only maybe 5 millimeters of stent protrude in the aortic arch. And after we do the CT, you can see there's very, a little bit, there will be dislodged from the, so after that we put maybe 1 or maybe 12 millimeters. Yeah, it depends on the, yeah.
Thank you.
I mean, is there any case, every case you use the preload wire, or I mean, it's like simple case, just don't use any preload wire, just accurate deployment. I mean, it's like.
Actually, in our hospital, we only have, I only have the C arm. We don't have the hybrid room. So actually, or make sure that there's no problem, I will always use the preload wire, because actually you can find in it's quite common that you bring up the stent and you cannot rotate it, especially in the shaky aorta or the very tortuous or type 3 aortic arch. So actually we do the preload wire in every case. Yeah, even in zone 2, so it can make the operation more easier. Yeah. And it's one of backup plan. If the stent is not deployed very perfect in the position, we also can put a stent in, even the stent may be a little bit dislodged, this position. Yeah.
So instead of the IVC balloon to control the flow, I mean, it's like we usually use the pacemaker to rapid pacing. I mean, is there any difference? I mean,
I don't have experience with the rapid pacing, and I can't do the procedure like that. So I have to use the IVC balloon.
Hi, I just want to find out. I know we're at a PMEG course, but would you have considered an in situ fenestration for the subclavian on the left side?
Pardon?
In situ fenestration.
Inside. Oh, inside to, yes. Actually, we start with the inside to fenestration. And one thing that we found is that if the stack of stent is quite hard, if the stack of stent is just maybe cross 30% of left subclavian artery, you can see the stent can be not open fully. And maybe in the future, the stent will be collapsed. So after that, we do the on-temple fenestration always, if it's possible. But in some case, like emergency, we have to cover it first, and we maybe do the inside later.
Okay, thank you.
Continuing the first question about the preloaded wire. So at the first, you put both of the preloaded wire to the LCCA.
Yeah,
to the same long sheet.
Yes.
And after that, you deploy the bridging stent for the LCCA.
Yes.
And after that, you pull the preloaded wire to the LSA to cannulate to the LSA. Is that correct?
Actually, we do like this. Actually, we try to go from the femoral first. So we put a long sheet. So the tip of long sheet is very close to the left subclavian artery. So if it's possible to cannulate from the femoral, we just only, after successful cannulation, we remove the preload wire from the left subclavian artery. Yep. But in some cases, we can use the snare to enhance cannulation more easier.
Can you do that to the 3 preloaded wire?
I not tried before, but maybe next time.
Thank you.
Okay. No.
Not one question.
Thank you for sharing interesting cases. I have tried once, like you, send the patients, but not successful because I forgot place a marker at the horn, and when I exploit the stand, it's very difficult to rotate. So, do you have any experience when you rotate the stand when it's into the curve?
Yeah. So it's a very good point. So actually, we face that problem. It's very difficult to rotate the stent when it stays close to the arch because the friction between the aortic arch and the stent graft. So in our case, we try to use the balloon fixation. So the balloon just like this one. We use balloon fixation and use the reducing wire to let the balloon rotate the stent. Yeah. Yeah. But in a simple arch like maybe type 1 arch and the healthy aorta, you can rotate the stent a little bit. Yeah.
Okay. Thank you, Dr. Johnny, for the sharing the excellent and interesting case. And we're gonna move to the next speaker, next session for the PMEG. We come back again for the lecturer. The next speaker is Dr. Vila. Dr. Vila is from the Kolat Maharaj Nakhon Ratchasima. Today he gonna talk about the intraoperative troubleshooting in the PMEG in complex aortic aneurysm. Dr. Vila, please.
Good afternoon, everyone. It is my last lecture, and from the morning to now, you learn a lot about how to modify the stent graft, and then we would like to show you. Everything is not perfect. In some time you had some unpredictable situation. And from our result in more than around 1.5 years, we have 27 cases. We did not update the number of the patient. Now today we perform 55 PMEG for jugular renal or thoracoabdominal aortic aneurysm. And the mean age of the patient is 72, male nearly 80%, and the most important risk factor is the hypertension. And we perform most of the cases thoracoabdominal aortic aneurysm, jugular renal, and pararenal aneurysm. And we perform 4 fenestration, 52%, and 3 fenestration, 22%. Technical success rate is 93%. We have a 2 case failure of the around 7% because of renal artery perforation because of poor control of the stiff wire. And another case present with a type 3 endoleak, and we have to re-balloon angioplasty, and the type 3 disappear. The mean operative time more than 4 hours. And the graft preparation time average between 25 to 30 minutes per one fenestration. And if to perform inner cuff, is the procedure time is longer. And look at the outcome, because we perform for complex EUR, we do PMEG only in a high risk case, but in the good risk we prefer to do open repair, and the mortality is quite high, 11%. 3 patients die from MI, from pneumonia and AKI. And we have most common post-operative complication is acute kidney injury because of a lot of contrast use, around 30%, and we have to perform temporary hemodialysis, 15% in 4 cases. And we have 1 case with spinal cord ischemia and complete recovery at 1 month. And one case present with grade 1 chronic ischemia and successful treatment with a conservative. And then I would like to show you for our case. This case you can see we miss decision. Really we choose to do the diameter reading time from the top to here, but for this case we just only do a leading time only the visceral segment, and for the first two stents we did not put the reducing time. And after we perform angiography, this patient present with the PAU at thoracoabdominal and infrarenal. And after we deploy the first two stents, I feel the fenestration is a little bit above the fenestration and the alignment is not perfect, and but we cannot do anything because of no leading side in the first two stents. We perform this procedure in the learning curve at the initial experience. And you can see another problem is the very small stenosis of the proximal SMA, and the visceral segment of the aorta is only 13 mm at the level of renal artery, and I use the reducing time about 1 millimeter smaller than the aorta. And we try to cannulate around more than 1 hour, but we cannot succeed. We can cannulate the wire to the SMA fenestration, but we cannot advance the wire into the SMA because of stenosis and maybe the angle of the SMA. Finally, because we are vascular surgeon, don't concern about the misalignment too much for this case. And for right renal, we can cannulate the wire, but after that we lose the wire. And for left renal, it's not so difficult. You can see the alignment for left renal is okay, for right renal it's misalignment. But the contrast, you can see the contrast because of the contrast through, you can see the reducing time at this segment, no aortic graft contact with the aortic wall, and the contrast the blood flow through the fenestration and into the right renal artery. And finally, we decide to open right lower quadrant incision, like you do appendectomy, and you cannulate ileocholic artery and advance the 4 Frenches into the ileocholic artery and do a retrograde angiography. But we cannot cannulate from the retrograde into the fenestration. We can advance the wire to the SMA fenestration. Finally, we use a snare from above and cannulate the wire into the snare and to create a 2 and 2 wire. The image is not so clear because we perform under the mobile C-arm. We use a snare here and cannulate the wire into the snare and pull it to clear the 2 and 2 wire. Yeah, you can see it. We can cannulate the wire. Left renal is okay. For right renal, we lose the wire, and after we lose the wire, we cannot cannulate into the right renal again. And finally, we deploy the SMA stent. And left renal bridging stent. And for the right renal, because we have a diameter reducing time and the angiography show no endoleak, and for this case we change the diameter reducing wire to permanent. We don't use the balloon to open the reducing time and let the blood flow through the right renal fenestration into the right renal artery. And the CT final angio is okay, no endoleak, and you can see the right renal artery, and CTA is okay. The right renal artery is have a blood flow from the fenestration with a diameter reducing wire of the stent graft. And the challenging case number 2 present with type 1A endoleak. And for this case, we plan to do inner cuff around 6 or 8 millimeter inside like a semi-branch. And you can see we use a PTFE and we use a double loop snare as a marker. And we use the preload wire into the inner branch. When we have to perform the inner branch, I routinely use the preload wire and diameter reducing wire with a 6O proline. And you can see for this case, the anatomy of the right renal is very challenging. We can cannulate the left renal. SMA first, it's not so difficult. We try to cannulate the right renal for more than 1 hour, but sometimes the wire can go inside into the renal artery, but when we advance the catheter, we usually lose the wire. And because of we perform the partial deployment of the PMEG stent graft, we have the space to cannulate into the right renal from below. You can see the right picture. For the left renal, we have a preload wire and inner cuff. And please see the left picture. We use the snare and snare the wire into the catheter and try to advance to the catheter and the wire from above, but we lose the wire. And again, we use a larger size of the sorry. You can see. We use the sheet of snare and then we snare the wire from above and put the snare inside the renal artery, and then we call this technique is the snare assist cannulation. And sometimes I think pre-cannulation in challenging anatomy maybe have a benefit. And then we advance the catheter from the arm and remove the wire from below. And then we use the amput short tip for good support. And for the right renal, we can cannulate the wire, but when we put the sheet, it usually lose the wire. And for this case, we come from below to cannulate to the right renal. You can see the sheet here, and the SMA come from above. And finally, we can complete the procedure. This is one of the most challenging case from my experience. And the challenging case number 3, we have to do a fenestration. This patient have a history of bilateral iliac stenting with bare stent, and you can see the problem is not easy to advance the modified stent graft in the bare stent, and you can see, and should be concerned about the iliac rupture for this kind of patient. And finally, we can aggressive and don't lose the stiff wire. If the problem is rupture, we can put the copper stent. And finally we can push and spin, like push and spin the stent graft. And finally we can advance and do the approach from the upper extremity from right arm. And then we can use this slide show we can open the diameter reducing wire with balloon and deploy the bridging stent. This slide show the final result. Show the problem of PMEG is no problem, but the problem is exercise complication. For this case, you can see because of we have a history of the open groin, and for this case we puncture at the distal EIA and close with the pocri. You can see the 12 inches. And after we close with the pocri, before we close the pocri, we advance the wire from the arm to the stenotic lesion. And then we pre-dilate with the balloon and deploy the superior stent from CAA to distal EIA. And the right picture show the final result is okay. If you are the surgeon, you can do open cut down into external iliac artery. Don't do like this case. And we usually closure the axially access with pocri closure device with the 90% success rate. The case number 4, present with a type 1A endoleak. And you can see we decide the fenestration. And you can see because of we use the C-arm, we misinterpretation. We think this one is a right renal artery, but really this one is SMA, not a renal artery, and that's why we misalignment of the fenestration. For the left renal, we use the inner cuff. You can see double ring inlet and outlet. We reinforce with snare. and we stenting of SMA, and we cannot see the right renal. The celiac is open. We can put the stent into celiac, SMA, and left renal, and for right renal, we have two options. You have two options. You cover the right renal, and another option, because this patient have a problem of borderline kidney function. I think if you cover the right renal, the problem may be AKI and maybe a long-term hemodialysis. And for this case, to open and bypass from the right iliac artery. Okay, this I show the SMA stenting, right renal stenting, and final angio you cannot see the right renal. We completely cover for the right renal. I discuss with our team, because I do our team perform the kidney transplant also, and to preserve the kidney. And for prevention of the long-term hemodialysis is very important for the patient. We bypass from the right iliac artery to right renal artery and cover with the omentum for prevention of graft enteric fistula. And this slide show the final result. And sorry for this case, we cannot show you for the CT because of after the procedure, this patient have some degree of CKD and GFR less than 30 and creatinine above 2, and we did not do the CTA. But this patient is still acceptable quality of life without hemodialysis. And the last case I would like to show you is this patient present with a type 1A endoleak, and we do a PMEG, and 1 year later, look at this slide. From our experience, for this case, the strut of the previous stent, you can see the renal artery. You can see if the strut located in the middle of the renal artery, if the Y go through here to here to here, the problem is a bridging stent collapse. And if the Y go to the last hole, go to here, not from here, it's possible to deploy the bridging stent with the inner cuff, because of the bridging stent cannot good sealing. For this case, like the above picture, and then for this case, we just put the stent only celiac and SMA, and for both renal penetration, I think is okay, because I fix SMA and fix celiac. I don't worry about the migration. But 1 year later, the problem is the migration of the both renal penetration and nearly complete cover for right renal artery. But the patient got lucky; he have a collateral to supply the right kidney, and for the left renal is more than 80% cover right renal, and the patient present with poor kidney function. And for this case, I think hybrid repair may be low, or you can do open repair, but the patient, this patient is not too fit enough for standard open repair. And for this case, we plan to do PMEG combined with hybrid repair. You can see. For this case, if we put the bridging stent through the start, it's possible to have a bridging stent collapse. And for this case, we have the inner cuff or inner branch for celiac and SMA, and we plan to cover both renal artery. And before deploy the modified stent graft, we do the bypass first. And you can see we use a preload Y and approach from right axillary access, celiac fenestration with and SMA fenestration and diameter reducing time. And after we do bypass from right iliac artery to right renal and left renal, and then we deploy the bridging stent. You can see this is a previous stent, the previous fenestration, and then you can see another 2 marker is the second. That means I perform a fen in the previous fen. Not so difficult, but not so easy. And this slide show the final angio. The angio is not so clear because of we use the C-arm. And the right picture show the final result, no endoleak. We can solve the problem of type 1A endoleak and good outcome of the bypass graft. Thank you. Really, we have another challenging situation, but the time is limit. any question or comment?
Thank you, Dr. Villa, for the challenging and troubleshooting and how he collect the problem. Do we have any question from the floor to ask Dr. Villa?
If no question, I think if you are cardiologist or radiologist and you want to do the PMEG, you should have the good collaboration with a vascular surgeon because in some unpredictable condition we need to do open, like the case that two cases that we perform a renal bypass that I show you. No question?
Okay, no question, I think. No question. Thank you, Dr. Villa, for the nice presentation.
Thank you.
And we are gonna move to the next session. The next session is the very interesting session for prepare for the PMEG. Dr. Cheyathorn will come and talk about the preparation and prepare for the hand-on the stent graft.
Okay, during this afternoon, we will hand on the back table preparation for the modification graft. And I will start with the case-based planning for the hand-on session. And this case will be go for live demonstration for tomorrow too. Let's start.
So there is two methods. First one is to use
sheet into the SMA before open, fully open.
The failed versions is about 50% of the step up. Thank you.
เกินไปแล้วมัน
And I think the filter reducing for me and our team, I think is quite important.
Yeah.
I think when we start in the few cases that I start, I did not put the encircling reducing tie. Sometimes it's not when we open the stent graft. Sometimes it cannot match to the target vessel. That is very difficult to cannulation.
Yeah.
And after we put this one, the reducing, it more easy. And sometimes it make it easy to turn that I showed you yesterday. It can pull it up a little bit and turn left or right a little bit to make when we cannulation. And we will reduce allow the 30 to the 30%, yes, more.มันขาดอ่ะกินข้าวเยอะเกินไป ได้มาเลยครับ
โ
แล้ว proximal อ่ะได้หมดก็ข้างบนให้ใหญ่หน่อยว่าปกติพี่เย็บหมดเลยว่ะเพราะว่าพี่รู้สึกว่าถ้าเกิดยังจำเป็นต้องหมุนมันจำพอหมุนได้ แต่ว่าถ้าจะกลางเลยใช่ไหมแต่ข้างล่างมันก็จะยังหมุนได้อยู่ดีใช่ไหมล่ะนั่นเอาอีกข้อนึงก็น่าจะพอนะน้องแป๊บหนึ่งท่าหยุดท่านี้แป๊บหนึ่งไม่พอดีจะบอกว่าตอนที่น้องฟีดอ่ะน้องไม่ควรจะฟีดท่านี้เพราะอาจารย์จะมองอาจจะมองไม่ค่อยเห็นไงถ้าเกิดฟอร์เซปมันบังอ่ะก็คือให้ปลายมันชี้อย่างนี้ครับตึ๊บจับฟอร์เซปจับตรงนี้แล้วก็ให้ตรงปลายอยู่แบบนี้อาจารย์จะเห็นเมื่อกี้น้องอย่างนี้ใช่ไหมแล้วอยู่ตรงนี้มันก็จะบังทำดูไม่เท่กันฮะผ่าตัดเราต้องดูความเท่เป็นหลักเนี่ยใช่แต่น้องต้องจับปลายให้มันเหลือนิดนึงใช่แล้วอย่างนี้ก็จะไม่บังตัวเองแล้วก็จันก็ไม่บังเพราะพอบังเซอร์เจนบางทีเซอร์เจนก็จะหงุดหงิดโอเคเราขาดคนอีกคนนึงไหมอ๋อหรือว่าต้องใช้คอนเทป
How long should reducing height on the stent graft?
You mean how many segments?
Yeah, how many segments?
Depend on you.
Yeah.
But normally we can do all the segments.
Yeah.
It may be easier. But in this case, I think Dr. Sheraton, they plan to the sealing at the proximal.
Yeah.
To the previous one.
Yeah.
That's why we just only the reducing only the 6 segment.
Yeah. Okay.
But if you want to go, and I think when we start, we can do all the segments. It may be easier.
Okay. Yeah.
If the proximal part is not reduced, and it will fully deploy, can we still rotate?
Yeah, sure. Yeah.
Oh. Okay.
อีกแป๊บนึงก็เสร็จแล้วเกือบฟูเข้าเผื่อฟูเข้าเดี๋ยวถ้าเกิดเอาไม่ขึ้นแล้วเดี๋ยว เอาฟูเข้าไม่ได้มันจะอีหลักอีเหลืออยู่ I think and the resheathing there are many ways to do that. You do yesterday we have the wall crimper from the two company and you do by handmade. because he has a lot of experience, we can do like this. I think when we start, we can snuggle all segment with the seal and the rubber, and after that we can do segment by segment.
Yeah, right.
And I think it depends on the size of the stent graft and the delivery system. If the delivery system is big and the graft is not big, it may easier to the resheathing.
Yeah.
very good แต่ว่าโชว์สเต็ปเร็วเกินไป เดี๋ยวเขาจะตกใจว่ามันดูง่าย เดี๋ยวติดให้เจนเจ้าคนเดียวเลยดีกว่า เดี๋ยวใส่ฮาร์ดคอลล่าก็ไม่ได้ อย่าเร่งไม่ต้องใจเย็นๆไม่ต้องเร่งไม่เป็นไรหรอกเสื้อฟูลงนี้ทุกคนเลยเดี๋ยวพี่ให้หาขวาอาจารย์เดี๋ยวหนูจัดการเองไม่งั้นเดี๋ยวจัดฝั่งโน้นมาเพิ่มด้วยไม่งั้นเดี๋ยวจะดึงเวลาให้เขาดูวิดีโอให้นิดนึงก่อนทดสอบทดสอบ
ได้ค่ะตามหนูได้แต่ว่าคนลุมแบบแต่ว่าดูลูกสาวของคนลุม
แต่ว่าเอาเข้าไปให้เขามาใส่ให้เขามาใส่ไม้ให้อาจารย์หน่อยพี่คะพี่เป็นหมดจันเจ้ามาใส่ให้หมดจันเจ้าก่อนได้ไหนพี่ไปใส่ไม้ให้อาจารย์คนหนึ่งได้ไหมใส่กันปะอะไรครับใส่ไม้เป็นไปใส่ให้อาจารย์
เดี๋ยวแป๊บนึง
นี่คล้องคอได้เลยครับ
อ๋อคอ
เนี่ยคล้องคอใช่ครับด้านนี้ไว้ข้างหลังตรง
แล้วต้องเหน็บต้องเหน็บคอเลยไม่เบี่ยงนะคะไม่ต้องเหน็บหูต้องเหน็บหูปะ
ไม่เป็นไรถ้าให้เหน็บหูอาจารย์สะดวกไหมครับถ้าอาจารย์มันจะหลุดไหมครับอาจารย์งั้นถ้าอาจารย์สะดวกเดี๋ยวผมก็ได้ครับ
ได้
ต้องแปะเทปนิดหนึ่ง
อาจารย์มาใส่ชุดนี้ก่อนแล้วค่อยใส่
เดี๋ยวให้ถึงแล้วมา
ไปเลยเอาพอก่อนนะขอโทษต้องเลือกเพียงคือคิ้วซุปเปอร์คอนะแล้วก็เดี๋ยวพี่บอกให้สโตก็คนหนึ่งกดสโตให้พี่ไปที่ลงล่างนะครับผม12:50
ค่ะตัวบางช็อต
ก็ชุบน้
ำพร้อมค่ะนอนน้ำค่ะ
เข้ามาตรงนี้
ต้องเอานี้ออกต้องเอานี้ออก
ผมแคปมา
พี่เข้าเคสได้ไหมได้หมดเลยขอเพียงส่งเสียงมา
ยังไงดีครับอาจารย์อาจารย์ช่วยอธิบายไหมครับช่วยอธิบายไหมครับหรือว่าเข้าด้วยก็ได้ครับ
เข้าไปลาตินักเข้า
นี่นึงเดี๋ยวกดสโตดิกดยาว ส่ไม่ออก
ขอเข้าเคสสักคนนะครับ
โอเค
ผมขอเข้าเคสด้วยนะครับตัวมือเบอร์7สวัสดีครับ
So we prepare 8 French sheet here for start and for the main body, and I will remove it. 2 procli here and 6 French sheet for pigtail for the aortogram, and 12 French sheet by brachial cut down. มาล่าง cut วายดำ ติดไหมไปเลยไปเลย
โผล่นี่เลย
เอาแบ็กอัพในสเตนนั่นหน่อย
กดแล้วดิ
ไปรูปมาจากกระเต็นเนาะ ค่ะ
So for today, for prepare the live case, we have a nurse team lead โดย Dr. Anand and his resident, and also the scrub nurse team. The head of the scrub team is น้องเพลงนะครับน้องเพลง breathing and ต๊อกแท็กครับ
Oh sorry
ออฟครับ
ได้ไว
น่าจะตรงไม่เซฟก็พิกเทลนิดนึงนะครับ
มันสามารถ
เมื่อกี้มันเหมือนจะไม่ดี
ผสมข้างหลังแล้วดูจอ
ก็เลย
You have another monitor yeah if you cannot see this one you can see this one
ตัวนะ
ครับเรียบร้อยแล้วชีตต่างๆ
ดูอะไรเกี่ยวเลยนี่มั้ย
อันนี้มันดิสเซกเนี่ยน่าจะได้ ประมาณนี้
เข้ามา
ได้
ไม่ได้เลยใช้มาก
ฟรีเวย์มัน
คือมันจะใหญ่กว่าแบบไม่
อ๋อ forward โฟนิดนึงครับ นี่ดูดน้ำยัง ดูดแล้วใช่ปะครับ
ที่เด็กแต่
เดี๋ยวเราจะขึ้นค่า
ขึ้นท่าศูนย์
ฉีดทีเดียว
L 15
มัน
โดยจะฉีด2 ท่า
ใช่ไหม
15
ครับ
ฉีดท่าเดียวหมดเลยเยอะ
ไม่ได้คนเยอะ
And when we deploy, we will use
เอา
the SMA for the reference.
สเตน
But
มา
this
ออเรน
case,
เต
the patient have the SMA. SMA has 15 degree LVO. That's why Dr. Cheton will bring the C-arm to the 15 degree. That's why the now
ปัดแล้วเนาะ
when the C-arm 15 degree, that make the SMA at the 0 degree.
ปัดสองนัด And during your first period, we have to check that our graft is good, like this, without twisting.
And now try to rotate and show the marker again. Okay. Egg marker is below the SMA.
Yeah.
And the lateral on the left hand side, that's the ID now. You will see that why we use the end snare. The end snare look like this one, the oval shape.
Yeah.
That is the keep the good visibility and the strength.
เตรียมขึ้น แล้วเดี๋ยวฉีดขึ้นแล้วค่อยฉีด
อันนี้วางไว้ตรงนี้ก่อนก็ได้นะ ไม่ต้องถือไปหมดบางทีอ่ะเดี๋ยวพี่ทำให้ดูเป็นการจะเอาออกก่อนอันนี้ใช่ไหมเราก็ม้วน2 รอบก็ได้บางทีถ้าคนเยอะก็โอเค
นี่เทียมกรีด
เล
เลยนะ
ไม่ได้
เทียมกรีดเลยนะ
ได้ไวแล้วบอกนะมือเพื่อน
แต่ว่าเหนียวมากก็บอก
เพราะว่าเคยใส่สเต็นท์มาก่อน
ขอแคมมัน
แคมป์กับ
แคมเอาไปทางนี้เพราะฉะนั้น exact เรากะว่าตรงนี้2 ข้อน่าจะอยู่โพสิชันนี้เช็คขึ้นนิดนึงครับประมาณนี้น่าจะดีโอเค
มันต้องคว่ำไหมครับ
เรียบร้อยแล้ว
forward
15 พอครับแอปเนี่ยหน่อยครับ ฉีดครับ หายใจได้ครับ
เอาหน้าจอเข้ามาหน่อยได้ไหมพี่เซนแต่จะโอเคไกลไปไหมเอาเข้ามานี่ไกลเลย ระวังที่ฉีดสีครับ Okay, you will see the SMA. The SMA, the olipid is the
ต้องสูง
the black one. And but now the penetration may be lower. We can put up it a little bit. That the doctor Cheton mentioned plan. We plan to get the proximal in the previous stent, maybe 2.5 the stent. And here.
แล้วก็ R 70
Yes, or higher, a little bit. Yeah, it may be the easy to bring it down more easier. And after that, we will bring the C arm to make the SMA perpendicular.
ประมาณมันน่าจะได้สักได้70ว่ะโอเค
ได้แค่75
โอ้โหมันติดดอท remove ดอทอันนี้ให้หน่อยได้ไหมครับ
ที่แปะ EKG อะครับ
ที่แปะ EKG อ่ะเปลี่ยนตำแหน่งดอทนี้ให้หน่อยได้ไหม
พอดีเป๊ะ
จะอยู่ข้างหลัง
เดี๋ยว โอเค
ได้แล้วครับ
เอาเตียงต่ำหรือเตียงขึ้นนี่หรอ Now at the AP view that we have the AP position, that's why we move to
เตรียมสีอีกทีครับ
lateral to make the perpendicular and we will check again. We will get the exactly
เท่าเดิ
the
มครับ
position, the lateral
นั่นแหละ
and the vertical
แอป
and
เนี่ยให้หน่อย
horizontal.
ครับ
ได้ไหมครับ
ฉีดครับ
It's not good. I think because the pigtail maybe is too high, we can bring the pigtail close to the SMA in more clearly to see the SMA.
ประมาณนี้แอปเนี่ยอยู่ไหมครับ ฉีดนะครับ
Okay. We can let
หาย
SMA
ใจครับ
I think the level is okay. Maybe lower a little bit. You can push it up a little bit. Maybe a 5 mm. พี่เจมส์ช่วยหน่อย
มาร์ค
เครื่องเขียนมากๆใช่ bring it up a little bit ตอนเชิญ
ประมาณ
โอเค
แล้วก็กลับ 15 เหมือนเดิมนะ โอเค แล้วเราปิดท่านี้ แล้วก็
ต้องหมุนเลขแปดเข้าหาตัวนิดนึงนะ
อีกรอบนะครับ ขอแอปเมียอีกทีนะครับฉีดครับ โอเคผมว่าน่าจะโพสิชันได้
อาจจะต้องขึ้นอีกนิดนึงมั้ง
แล้วก็รีโน่ต้องขึ้นมากเล็บรีโน่ครับ ขอบล่างเนาะ
เอาหน้าจอเข้ามานิดนึง โอเค พี่เจมส์ให้มันอย่างนี้นิดนึงให้โอเค น่าจะได้แล้วมั้ง
เป็นประมาณนี้
โอเค ส่วนสีเขียว SMA นี้กวางไอ้ที่แปะนี่กวางแล้วป่ะโอเค I think the position is okay. We will deploy the SMA penetration between the green arrow and the light arrow that lower edge of the right renal. Yep. The proximal now is open. Okay. You will see the egg marker Dr. Chathon keep in the AP position. Right. Okay. Okay. You will see the encircling reducing time had the function like this with more taper. ต้องหมุนออกนอกตัวอีกนิดนึงนะสวยงาม
ปล่อยบน
Yeah. But now the penetration of the SMA now open. We open the proximal top cap to fix the proximal. And the next step we will try to cannulate the SMA.
แคปเฉยๆกันครับได้แคปเลยนะครับ
เอาไว้ในกล่อง
เอาชีสมาหน่อยกันผัดใส่ผัดใส่เขาจะใส่อ๋อต้องใส่ผ่านนี้ใช่ไหมใส่
อันนี้มีอะไรอยู่อ่ะ
ซุปปลาคอใส่ซุปปลาคอทีนี้
ไม่ดึงออกเลยดึงตัวประกอบไปเลยแล้วก็นี่มัน
ใส่อันนี้เข้าไปเลยก็ได้
มันแต่ว่ามันไม่โผล่อยู่แล้วมันไม่อยู่ในฟิวอยู่แล้วลักไก่เลยอ่ะถูกต้องและถูกใจแล้วเนาะอันนี้มันไม่ได้โอเวอร์วานนะพอมี12เฟ้นอยู่แล้วก็เอา
35
เอาแคทมา
เนี่ยเราลงไปล่างเลยก็ได้
but in this but this step we can move just a little bit we can move because of we did not the fully deploy and we have the
มัน
reducing part
แอป
we
เปิล
can
จะ
move
ไปไม่ถึงยามแต่มันยามแค่ติดไปเลยขอเอา12ขึ้นนิดนึงครับได้แล้ว
ชีสมันชนใช่ไหม
ใช่ชนครับนะครับเอาชีสขึ้นนิดนึงครับ
ให้เป็นสเต็ปไปไหมขอแล้วกันชิ้นใหญ่เข้าไปก่อนทำไมล่ะOkay. For easier, when cannulate the blunt, we will make it perpendicular. Yes.
เตรียมมาร์กเกอร์ออกเตรียมเอามาร์กเกอร์ออกให้หน่อยครับติดมือไหม
ตอนนี้มันกี่องศาแล้วนะโอเคนะ it's going out yeah okay check the position. Now we are in. Yes.
Why ค่ะ
ชีสแต่ชีสมันจะไว้ไม่ได้ไงเพราะฉะนั้น
ใช่ต้องออกชีสดูดิครับออฟยาวครับ
เรียกว่าอะไรนะ
ออฟถอยยาว
ออฟยาว
ได้ไวครับแคมตัวครับ
Now we get the SMA We got the SMA. We will leave the stiff wire. The stiff wire we use the super core. You can use the super core, Rosen wire, or the Ampere chop tip, something like that. And the next one we cannulate the next the lightly now. And Dr. Sheraton will open the stent a little bit until the lilinal open, penetration open.
ขอไซส์พังเชอร์หน่อยจ้า
เอาวายมาก่อนเพราะถ้าใส่ฟังเกอร์มันใส่แคทไม่ได้
For 12 French sheet, when you insert or 2 or 3 Y for cannulation, you have to separate puncture into many quadrant of the 12 French.
Wow. Good. No need the catheter.
ใช่หรือเปล่า
ไม่ใช่ SMA
ของ SMA
This one we already done. Yeah. We do the SMA. เตรียมไว้ก่อนครับ
ข้างบนตะกร้า
Why fill in the SMA? Okay. No. ใครโดนเลยใครโดนซอฟต์โกนโอเคเอาวายมันลงมาแล้วใช่ไหมเอาแคทลงมาก่อนก็ได้แล้วเดี๋ยวค่อยสะบัดเอาใช่ให้เปิดสักนิดนะต้องไอเอ็มละOkay, we go out the penetration, but now we did not go to the lightly now. Yep, but the outside the graph already. Good, perfect. And the next step we will check for sure that we are in the lightly now. Yep, we are in.
ยัง
อะไรนะ
อย่าเพิ่ง
ว่าอะไรนะ
อย่าเพิ่งนินทาใคร
ได้แล้วเราอย่าเครียดเราต้องถ้าเราเครียดมันจะนินทาไม่สนุกของใจลืมไปว่าเราเล็กคอร์ดอยู่
ใช่ไม่ติดปากนินทาได้ครับผมบ๊ายบายครับแคมป์มานะครับ
แคมป์ดัก In our practice, we always use the super core. The super core, I think, is quite good. The stiff wire, it had the tip, long soft tip, 10 centimeter. That's bad, that's good. I think sometimes, but it's quite soft. It not make the renal injury. But sometimes it can occur. Yeah. After we place the slip wire, we completely deploy the main body.
แต่ว่าเราไม่ได้ใส่สองข้างแต่เราต้องดันไว้
And next step we bring the nose cone out. ระวังชีสเนาะชีสอยู่ไหนโอเค
พร้อมค่ะ ออกเลยนะคะ
We always put the long sheet. We always put the long sheet before we review the living size. Yeah. Put in the one that we can choose. Which one is maybe difficult to advance the sheet maybe.
ย่ำจับชีสให้หน่อยครับ
Oh, yeah.
ไว้นี่ก่อนก็ได้ครับเดี๋ยวติดบอลลูนนะ
ไม่ใช่
ขึ้นเลยค่ะ อาจารย์ไม่อยาก
ผมว่ามันตรงอยู่แล้ว
เดี๋ยวเราใส่ชีสไปในร้านอันหนึงก่อนได้ไหมดีไหม
เอา SMA นะครับ
จะได้สเตเบิลไม่ใช่ลีโน่ก็ได้นะเพราะว่าเราจะได้
เอาเราดีพอยลีโน่ก่อนลีโน่7ลีโน่
ลีโน่เส้นนี้ก่อนเส้นนี้ลีโน่
เส้นนี้ Actually, when I do it alone, I will arrange the Y SMA in the middle, right on the right, left on the left. Yeah.
นี่มันของยี่ห้อเดียวกันมันเหมือนสีนี่มันไม่เหมือนกันสักสีนึงมันดูแบบดูดาเบสเลยนะปล่อยวางนิดนึงให้ไปวางเข้าไปนิดนึงวางถอยโอเคที่ถอยให้วางถอยไฟไอ้เดเลเตอร์มันน่าจะชี้จิ้มแบบอะไรนะออนไลน์
ไว้ถอยนี่แคมป์นะครับได้ไวครับ
ไม่เอาแล้วขอโทษขอไว้ก่อน
นี่ใหม่ดูดีพลิกไวนะถึงแค่ประมาณนี้ครับอาจารย์จะดันก็ได้ครับ
ได้
เป็นเกียรติ
This is for the overlapping. Yeah. The next segment had the reducing. You will see when it pop up. Okay. เอาเลยใช่ไหมหรือ
ครับ
เอาเลยนะ You will see.
เ
1, 2, 3.
So you can hear the sound click
Really?
on my
น้องผูกไว้แน่นเกิน
My fellow has a strong hand, so she tied very tight.
ไม่ต้องครับอย่างถูกต้องกับถูกใจแต่พอลองมันก็ดึงลงนะพี่เคยเห็นเขาลองนี่แหละอย่างนั้นพี่ก็ดึงน้องเคยลองยัง
อะไร
You see the sheet protect the lining now
ไปเรื่อย
อีกนิดนึง
ๆดังแป๊กจ้ะ
รู้สึกไหมไหม
อีกนิดนึง
เฮ้ยแต่มันกระเทือนมาถึงนี่จริงว่ะไม่กระเทือนสุดเลย
แล้วก็นี่อีกทีหนึง
โอเคเดี๋ยว the last one มอโอเคยังกระเทียมมอ
เราไปบอลลูนโอเวอร์แลปบนเลยไหมครับ
เมื่อกี้มันขึ้นไปแล้วข้อหนึ่งนะจะเอาอีกทีนึงก็ได้นะ
เอาบนสุดเลยนะครับอุ๊ย
พอลองก็ดึงขึ้นดึงลงอย่างนี้แหละพี่ก็อีกนิดนึงโอเค
ครับขึ้นเลย โอเคพอแล้วครับบอลลูนเอลต้านิดหนึ่งครับ BP ขึ้นหน่อยนะ โอเคค่อยๆถอยบอลลูนอย่าพันโอเคเอาไว้นี่ออกเลยก็ได้ออกนะครับสีมาครับ
เติมสีตัวไหนเพิ่มสีแบบไหนก็ได้
แต่สีทำอะไรอ่ะ
ฉีดลีนอก
ต้องไหม
นิดนึง
ได้เอาถูกต้องก็ได้อะพี่เตรียมไอ้นี้ให้หน่อยบีครับ27ได้ไหม
มียาวกว่านั้นหน่อยไหม3น่าจะได้ยาวเฟ้ยเลย38เลยครับก่อนไปเฟอร์พอดี
เปิดอินดิเคเตอร์
คิวในคอมพิวเตอร์เอาใหม่
ใหม่ไปเลย
อันใหม่
ไม่เป็นไรเดี๋ยวที่เหลือพี่ปอยจ่ายเดี๋ยวอะไรเกินเดี๋ยวพี่ปอยจ่ายให้นะเรคคอร์ดไว้เรียบร้อยแล้ว
มีในตะกร้าล่างกลางสองตรงกลางนะคะ
เอาเลยเอาจะใช้อะไร
So we will use the 6 mm by 38 B graph.ปล่อยชีทนิดนึงครับปรับฟิก12นะครับจะเท่านี้ได้นะ
พี่ว่าต้องเอาออกมาอีกสักนิดนึง
ออกนอกครับ
อ๋อเข้ามาปุ๊บผิดไม่งั้นเดี๋ยวขอบบนมันจะไม่พอ
ครับ
โอเค
เดี๋ยวผมขอถอยชีทนิดนึง
น้องเคยไหม and by the fin the bridging should be placed inside the aorta allow 5 millimeter to have space to stick with the fenestration hole and need to be square at the proximal of the breathing
เดี๋ยวแผลบนใช่เดี๋ยวแผลบนคิดข้างหน้าเดี๋ยวถอยคิดต่อนะครับมีเสร็จเร็วนะครับสุดเลยขึ้นมาตั้งนะบอลลูนมันหลุดออกมาขึ้นเบาๆหมุนขึ้นหมุนทีละน้อยครับ
ชนเอาใหม่ไม่ได้ชนเอาใหม่เดี๋ยวแป๊บนึงนะให้เพื่อนเราเอาบอลลูนเข้าไปอีกนิดนึงขึ้นบอลลูนเอาชิดถอยนิดนึงถอยชิ้นนิดนึงถอยชิ้นนิดนึงช็อตต้องกลับมาคู่แล้วก็ช็อตมันนิดนึงช็อตเต็มโอเคเปลี่ยน direction มัน
เร็วเลยก็ได้
by the principle should be use the 8 balloon to fairing maybe 2 millimeter larger but for save the cost we use the beta balloon to overfreight until the lead bird yeah when we use lead bird maybe higher up around 6.6 but the by principle should be over 2 millimeter ใส่ ให้เอาอะไร
ได้ไวครับ
ใช่
ได้ไวครับขอแค่มาหนึ่ง
เอาชีสใส่เดลเตอร์นะครับ
60โอ้ขอโทษถอยจอย
บ้านผีสิง
เสียงเหมือนพี่ปอยเลย
บ้านผีสิงเสียงเหมือนยังไงนะ
เสียงดูชรา
เสียงแก่อัมบอกแก่
เสียงแก่
ไม่ตั้งฉากเนาะ
ต้องไปประมาณ70แล้ว
ใช่ถ้ามุมนี้ไม่ตั้งฉากก็ต้องอีกมุมหนึ่ง
แอลอ่ะ
เผื่อว่า
โอ้ไม่ต้อง
เดี๋ยวให้ชีสเข้าไปก่อนก็ได้นะ Now sheet in the director sheet in วายถอยนิดนึงวายถอย โอเค โอเค
โอเค
ไม่ดี
มันเกิน
เอาใหม่ ไปอีกด้านหนึ่งน่าจะได้มากกว่า ระวังหน้าแข้งนะพี่น้อง เอาอันนี้ไหมเอาอันนี้ไหมติดแล้วเหรอติดแล้วต้องมาเตียงขึ้น
ไม่ได้ลอง
เอามาชนด้านล่างแล้วแหละ ต้องกลับมาด้านนู้นแล้วไหมพี่พลอยเอาจอหลบโอ้สุดแล้วอ่ะน่าได้อยู่มันควรจะได้เลยอีกอันนิดนึง
ไม่ได้
เอาเตียงมาด้านเราดิแม่จอมต้องอ้าไว้ก่อนเดี๋ยวมันโอเค we try to make it penetration perpendicular but I think this is the limitation of the pen sometimes we cannot adjust more than 90 degree
contract
okay and I think this is the best position that we can do okayต้องดึงชีทขึ้นมาอีกนิดนึงจะได้ดู
พี่อ้อมฝากพลิกชีทนะครับพลิกชีทกับไว้
โอเคนี่พี่ตรวจมาแล้วคุณโอเค you see the first barn ตรงปลายชีทเลยอ่ะขึ้นหน่อย
ขึ้นอย่างนี้ไม่ขึ้นขอบชีทเลยมีโค้งๆครับตรงครับครับตัดเล็บ
ตัดนิ้วนี่คือไม่ต้องมีแล้วเลยนะแต่ผมว่ามันน่าจะลึกกว่านั้นได้นิดนึงนะแต่ว่ามันยาวใช่ไหมครับมันมี9 แต่ว่าเปิดมาตั้งแต่ก่อน8ก็ได้
8แล้วก็เอาบอลลูน10สั้นๆมาครับผม
ดูอามาด้า10 20นี่นะมีเป็นเบสิก
ชีตวิ่งอยู่นอกเส้นเลือด
น่าสนใจแป๊บหนึ่งเอาแคปเข้าไปเลยที่วายนี่แล้วลองฉีดดู
ครับ
แคทนะแคทมาด้า
อันนี้คือเราเห็นแล้วเรารู้สึกสงสัยว่าเอ๊ะทำไมชีสที่มันเหมือนมีมาอยู่นอกตัวนอกตัวไม่นอกตัว SMA หรือเปล่าแต่จริงๆมันไม่ควรไงแต่ว่าอาจารย์ทำชี้ให้เห็นแล้วเราก็ลองดูใส่เข้าไปนิดนึงได้ไหมโอเคแล้วเดี๋ยวลองซีฟันแคทดู We try to check again because of we have wonder is it inside the
เดี๋ยวขอ F เนี่ยนะครับ F เนี่ยครับ
I will be back with the final angiogram again after this one. Okay, I think we are in. น่าจะเข้าอะไรนะก็คือน่าจะอยู่ใน SMA อยู่แล้วใช่ไหม โอเคโอเคเซ็นมาครับ
ติดไหวนะติดก่อนนะ
โอเคก็เสร็จตรงนี้น่าจะดีแล้วเนาะดีขึ้นเลยนะครับเอาเท้าอยู่
เอาจะโพสต์อยู่นะครับ
จะใช้สิบไหมใช่ไหม
จริงๆมันขึ้นเบอร์ได้เลยเพราะว่า SMA มันใหญ่
อ๋อใช่ครับ
เร็วครับ
เดี๋ยวนะแบบนี้โอเค1 2 3อันนี้ก็น่าจะ
F เนี่ยหน่อยครับไม่น่ามีอะไรนะพี่ยำผมพัดเร็วไป
เอียงนิดนึงได้ไหมเพราะว่าไม่รู้ไอ้ดำๆข้างบนนั้นมันเป็นบลาหรือเป็นอะไรเอียงน้อยลงนิดนึง
หายใจได้นะครับน่าจะโอเคครับผมว่าไม่น่าต้องแฟร์แล้วนะเรา
ตอนนี้มาแฟร์อีกทีนึงนะแต่เมื่อกี้ขึ้นสุดแล้วเนาะ
ครับเมื่อกี้ขึ้นสุดแล้ว
ขึ้นอีกทีนึงก็ได้นะให้มันแบบขึ้นกับไปตรงเป็นแบบต่อถอดบอลลูนโอเคพี่จัดทีเดียวเอาแล้วนะ
แป๊บนึงคือ
เอาไว้ไอ้บอลลูนบอลลูนเข้าไปนิดนึงโอเค Then we flare the proximal with the same balloon
But you can see that the balloon fit to our fan already, so I think it's enough for planning. เร็วครับ
เพราะบางทีถ้าวายมันถอยมันจะเสียความแข็งแรง Perfect. Very good. ต้องถือนิดนึง
เมื่อไรครับชีทอยู่ไหนครับเนี่ยเดี๋ยวถอยขึ้นมาก็พอไหมครับ
อะไรเอ่ย
ชีท
ก็ดีนะ แล้วก็เราฉีดไปข้างหลังจากข้างล่าง
วายดำนะใช่พี่ยอมตัดจากชีท6เลยนะ
Now I think we already done for the aortic stent and the bridging stent. The next one we will do the final angiogram. But in this case, that the planning yesterday, the patient had another re-entry. I think that's the discount. We can collect just only this part before. And in the future, if the dissection has progression, I think we will collect again.
ล่างนี่ไหมหัวอยู่ขอบ12
นี่สูงไปไหมไม่หมายถึงพิกเทลเพราะว่าเราแค่ต้องการดูโอเวอร์แลปตัวนี้นี่เนาะแค่ปลาย12เซนน่าจะโอเคสีเอาเท่าไหร่เลย
20 อ๋อม่องเปล่าอันเดียวแอปเนี่ยครับฉีดครับ มีขึ้นอยู่แต่ว่าข้างล่าง หายใจครับปรินนะเรียนที่ล่างว่ามันบกได้ So I think we already correct the planning part, and the lower part there are still some entry. I will do the follow up and do the state operation in next time.
Okay, we keep on the perfusion on that.